Hello everyone and welcome back to Module 2 where we're going to be discussing sciences in dentistry. First, I want to make a couple quick notes. We've had one change. In the last module, I just said that we would be discussing questions throughout the week on a Facebook group. We've decided to use the discussion board feature on the class website for those discussions. So be sure to log on and check out the discussion question, and if you will answer the questions in a single post and then comment on at least 2 of your classmates' posts so that we can use that discussion board to interact with the topics there. The second is that the figures that I use in the lecture, those are all taken from your textbook unless I note otherwise. Alright, so let's get started. So as a dental assistant, why is it important for you to have an understanding of science? Well, science is the foundation of dentistry. Therefore, it's necessary for you as a dental assisting student to understand those basic concepts in science so that not only so that you can communicate effectively as a healthcare professional with your colleagues, but also so that as you are providing dental care and dental treatment and you're assisting in that care with patients, you can understand what's going on. So we're going to be discussing 4 different chapters in this lecture: general anatomy, general physiology, oral embryology and histology, and head and neck anatomy. So general anatomy is basically the study of the shape and the structure of the body, whereas general physiology, that's the study of how the body actually functions. And many times because of that, you'll often see a class entitled anatomy and physiology, because those two are so closely related, because one continuously influences or affects the other. For example, the function affects the structure, and therefore the structure also affects the function. So as you can see in this slide, we are going to be covering a lot of information in this lecture. In fact, it's kind of like we will be trying to take a drink from a fire hydrant. Okay, so you will have a lot of information and a lot of details presented to you in this lecture. So please feel free. In fact, I encourage you to listen to the lecture a little at a time. Maybe listen to the lecture for one chapter and then take a break, go for a walk, go for a run, take a nap, do whatever you want to do to give yourself a break. All right, let's go ahead and get started with general anatomy in chapter 6. Again, we're going to be learning a lot of new key terms. It's important that at the beginning of each chapter that you read through those new terms and become familiar with their definitions and also the pronunciations. Again, it's like learning a new language, and you're going to continue as we go along to rapidly increase your vocabulary as the course progresses. So it's crucial that you spend time with each chapter learning those terms, because it's only going to continue to build as we go along. All right, so just like we have cardinal directions such as north, south, east, and west to navigate a map, we have different basic anatomical reference systems that allow us to describe the body so that we can communicate clearly and effectively with one another. So for example, when you ask Google Maps to give you directions, you have to know your current location or your starting point in order for your route to be determined so that you can get to where you want to go. So when we discuss the anatomy of the human body, our starting point, we have to know the starting point, and that is described as anatomical position. So you can see this figure here. The lady is standing in anatomical position. That refers to the body that's standing erect with the face forward, feet together, and the arms hanging at your side with your palms facing forward. So in this picture right here, her palms are not quite exactly facing forward like they would normally be in a true anatomical position. So if I could change anything about that figure, I would make that change. So when we discuss the body further, we use directions. Okay, so we think of them as pairs of opposites. So just like on a map, we use north and south, or east or west, or up or down, right or left, front or back. Okay, so we're going to discuss those directions. The first pair we're going to discuss is superior and inferior. So superior is above or toward the head or the upper part of the body, whereas inferior refers to below, away from the head or toward the lower part of the body. So you can see those marked here on this figure, superior and inferior. The next pair is anterior and posterior. Anterior refers to toward the front of the body, whereas posterior refers to towards the back. So, for example, anterior, the nose is anterior to the ear, whereas spine is posterior or behind, located toward the back of the heart. The next pair is proximal and distal. Proximal is closer to where the body part originates or where it attaches to the body, or in other words, closer to the trunk of the body. Whereas distal refers to away from where the body part originates or attaches, or farther from the trunk of the body. So for example, the elbow is proximal to the wrist, or the elbow is closer to where the arm originates to the body as compared with the wrist, whereas the fingers are distal to the wrist. The fingers are farther away from the trunk of the body or where the arm attaches to the body. The next pair is lateral and medial. Lateral is away from the midline, and medial is toward the midline. Okay, the midline is just that middle portion of the body. So for example, the ears are lateral to the eyes, or they're further away from the midline. The nose, we would say, is medial or closer to the midline as compared with the ears. The next pair is ventral and dorsal. Ventral refers to the front side of the body, and dorsal refers to that on the back side of the body. So the nose is on the ventral side or the front of the body, and the spine is on the dorsal side or the back side of the body. All right, so another way that we can describe the body is with planes. Okay, now you will use these planes, especially as you describe, as you're looking at radiographs, for example, a cone beam CT image. That is going to be very important that you understand these planes. So be sure to take some time to understand these planes so that as you're beginning to look at CT scans, for example, or cone beam CT scans, which many dentists have in their office now, you'll understand what those are referring to. So the first plane is the mid-sagittal plane, and that is seen here in purple. And when we're talking about mid-sagittal plane, that divides the body from top to bottom into equal left and right halves. Okay, if we want to talk about right and left halves that are not equal, we use the term sagittal plane. Okay, so mid-sagittal, though, is always meaning you draw a line directly in the center of your body, and it divides the body into left and right halves. The second plane is the horizontal plane or the transverse plane, and that is seen here in yellow, and it divides the body into its superior and inferior portions, or upper and lower portions. The third plane is the frontal or the coronal plane, which is seen here in blue, and that divides the body into anterior and posterior or front and back planes. All right, so as we continue on looking at general anatomy of the body, the human body is incredibly complex, okay, but it can be easily understood when we break it down into small units. So this figure shows the human body from the simplest to the most complex, beginning with the fertilized egg, which divides into two cells and then continues to multiply and multiply until tissues such as epithelium, muscle, cartilage, bone, and blood are formed. And then those tissues combine to form organs such as the skin, brain, heart, liver. And then those organs form different body systems like the central nervous system, the respiratory system, the immune system, and the cardiovascular system. Okay, so we're going to talk a little bit more about cells. So cells are the basic units of structure of the human body. Your body is made up of approximately 75 trillion cells, and each of those cells have a designated purpose. Each cell can react to stimuli, They can transform nutrients into energy, they can grow, and they can reproduce. And cells all have different shapes based on their function. They have various lifespans depending on their function and their type of cell, and they have unique functions. The term that we use to describe the specialized function of the cells is differentiation. And what that means is basically that a brain cell, for example, cannot do what a red blood cell does. There are also cells that are undifferentiated. And the undifferentiated cells are cells that are not specialized yet. They're not dedicated yet to a specific function. And that type of cell is also called a stem cell. And think of a stem cell like a blank tile in Scrabble. Okay, they have a lot of potential. They can become like the blank tiles in Scrabble can become any letter that you want them to be, just like an undifferentiated cell has the potential to become lots of different types of cells. Okay, so there's two different types of stem cells, and a lot of times you hear in the news kind of stem cells being controversial. Well, we're going to talk about there's which type of cell that is typically referred to in that controversy, and that's embryonic stem cells. Embryonic stem cells, as their name suggests, are derived from embryos, but those are usually embryos that are 4 to 5 days old that were fertilized in vitro, which means in a laboratory, not in a woman's body. So embryonic stem cell research is controversial, and as I mentioned, in many countries have placed legal restrictions on this type of research. I don't want to oversimplify a very complex issue, but basically the argument for or against embryonic stem cell research lies in that ethical dilemma of choosing between the duty to prevent or alleviate suffering by using those embryonic stem cells to do research to potentially develop cures for diseases. So the argument is either the dilemma of choosing that, of curing diseases, or and the duty to respect the life, the value of human life, because the embryos are destroyed when these embryonic stem cells are harvested from those embryos. So that's the debate there. Adult stem cells, on the other hand, those are the immature cells which have not been dedicated to a specific function, and it's a little misleading. These are not just stem cells that are found in adults. Adult stem cells are found in adults and children. This is basically this term, adult stem cells, is just used to differentiate, to set it apart from the embryonic stem cells, which is what we just discussed. Now, adult stem cells can be found in bone marrow. They're easy to obtain, and we've been using these types of stem cells in bone marrow transplants for years to treat certain cancers such as leukemia. Stem cells can also be found in blood, skin, retina, skeletal muscle, brain, and certainly of interest to dental professionals. Stem cells have also been found in the dental pulp, and so you'll learn later that the dental pulp, that's another term for the nerve, which is located in the center of the tooth. And there's been a lot of research come out recently that's discussing using stem cells that are found in teeth, for example, extracted wisdom teeth or third molars, to do research. All right, so let's talk specifically about the structure of cells. Each cell is composed of several different structures. We're going to talk about three here: the cell membrane, the cytoplasm, and the nucleus. The cell membrane is what surrounds the cell, and it helps the cell maintain its form, and it separates the cell's contents from the surrounding environment. The cell membrane has certain physical and chemical properties on that membrane that allow it to recognize and interact with other cells, and it also helps decide what can enter the cell. So certain nutrients can enter the cell, and then it helps determine what leaves the cell. And so the waste products that are produced from the functions of those cell parts, those will leave the cell. And so think of that cell membrane as like the doors and windows of a building, determining what gets to come in and what gets to go out. The cytoplasm as you can see here, just past the cell membrane here, kind of all throughout the cell, is the gel-like fluid that's inside the cell, and that's what contains the organelles. And the organelles are the parts of the cell that actually do the work to manufacture, modify, store, transport proteins, and then also help dispose of waste. The nucleus, as seen here in the center of the cell, right in here, is the control center of the cell, which directs all of the cell's activities. It contains the genetic information, and every single cell, the nucleus, has a complete set of the body's chromosomes, which includes the DNA and the RNA. All right, so we talked about cells, and next we're going to talk about tissues. The different types of tissues, or different types of, when millions of the same type of cell join together to perform a specific function, tissues are formed. And so there's 4 main types of tissues that we're going to discuss: epithelial tissue, connective tissue, muscle tissue, and nerve tissue. So the first type of tissue here is epithelial tissue. And you can see this is the cellular structure of epithelial tissue. It provides protection, such as it serves as external coverings, like your skin is composed of epithelial tissue, and also it lines the internal linings of the nose, the mouth, and the internal organs contain epithelial tissues. It also secretes substances such as hormones. As you can see here, epithelial tissue are responsible for secreting hormones, perspiration, and mucus. Second type of tissue that we're going to talk about is connective tissue. Connective tissue provides the support for the body, and it connects the organs and the tissues. So examples of connective tissue include fat, bone, the ligaments and tendons, and then also blood. Okay, blood is not something you normally think about. When you think about connective tissue, it's not the first thing that you think of. You think of more of the bone and the fat and the cartilage and the ligaments and tendons, but blood is also considered a connective tissue. The third type of tissue is muscle tissue, and there are 3 different types of muscle tissue. Okay, the first is striated muscle, which is also called skeletal muscle. You can see the striations here in the muscle. And the striated muscle or skeletal muscle is responsible for voluntary movement, such as the movement in your arms and your legs. The smooth muscle, on the other hand, you can see it lacks striations, is responsible for the involuntary movement. So digestion and many of the internal organs have smooth muscle. The cardiac muscle also has striations like the striated muscle or the skeletal muscle, but the cardiac muscle it makes up the walls of the heart and helps pump blood out of the heart to the rest of the body. So the fourth type of tissue is nerve tissue, and this is a picture of a neuron or a nerve cell. And nerve tissue can be found in the brain, in the spinal cord, and in the nerves. And the nerve tissue can be motor or sensory, and so that means basically it can stimulate a muscle to contract, so that's the motor part, or it can be sensory, meaning that it has the ability to react to certain environmental stimuli, so like hot or heat, cold, light, or pressure. And when we discuss the cranial nerves, we'll discuss differences between which nerves can be motor and which can be sensory. All right. So as we previously discussed, when millions of cells of the same type join together to perform a specific function, tissues are formed. And then when those tissues group together to perform a single function, organs are formed. Okay, so some organs, such as the stomach, the heart, and the lungs, can contain all 4 types of tissue. When those organs work together, body systems are formed. Okay, and I have those listed here. So we're going to talk about one in particular. The digestive system includes several different organs, like the esophagus, the stomach, the small intestine, and the large intestine. Each organ has a unique function as food is ingested, digested, and as the nutrients are absorbed. So the body's comprised of 10 major body systems, and we will discuss those in more detail in the next chapter. So as we finish out our discussion of general anatomy, we are going to discuss the body cavities. Okay, your body is divided into a dorsal cavity and a ventral cavity. Remember, dorsal means back of the body. And that dorsal cavity includes the cranial cavity, which has the brain, and the parietal cavity, which has the spinal cord. We're going to also discuss the ventral cavity, which has the thoracic cavity, the abdominal cavity, and the pelvic cavity. And you can see here the thoracic cavity contains the heart, lungs, esophagus, and trachea. The abdominal cavity contains the stomach, liver, gallbladder, spleen, and intestines. And then the pelvic cavity also contains a portion of the small and large intestines, the rectum, the urinary bladder, and the reproductive organs. The body is also divided into body regions, the axial region and the appendicular region. The axial refers to the head, the neck, and the trunk, or the main central portion of the body, whereas the appendicular refers to the arms and the legs. Okay, so it's really important to remember that your patients are more than just cells, tissues, organs, and body systems. It was once said that patients really don't care how much you know until they know how much you care, and this is so true. So remember to treat your patients like you would want to be treated, and how you would want your family, and how you would treat your family and your friends, and how you would want them to be treated. All right, so time for a break. Go take a walk, go for a run, take a nap. This concludes the first portion, or chapter 6 of the first portion of the module 2 lecture. This is actually a lion that I saw on safari. I had the privilege of going to Africa, had some family members living there in Kenya, and this was actually on safari in the Masai Mara, which is actually close to the Serengeti. So we got really, really close to this lion. Hopefully you're not sleeping like this lion wanted to be. But anyway, take a break and we'll see you back in just a minute. All right, so in Chapter 6 we discussed general anatomy, or the structures of the body. In Chapter 7 we're going to be discussing physiology, which will give us an insight into how the body functions. And although it's the dentist that has the sole responsibility for the diagnosis and the treatment of the patient, it's vitally important for the entire dental team to understand both anatomy and physiology. As a dental assistant, when you know the appearance of normal anatomy and normal physiology, how the body should look and how it should function, you're more able to discern abnormal medical and dental conditions. And this really makes you a valuable member of the dental team. All right, so the 10 body systems, we're going to start by discussing those, are listed here. Each body system has specific organs which work together to perform specific functions. So we're going to discuss each of these systems individually, their components, their functions, and some of the disorders that affect them. So, however, it's important to understand that these systems do not operate independently. For example, when you exercise, your muscular system needs extra oxygen, so your respiratory system increases its output to supply this increased demand. Another example is the connection between the reproductive system and the endocrine system. The reproductive organs, like the ovaries and the testes, function in response to hormones that are produced by the endocrine glands of the endocrine system. All right, so first let's talk about the skeletal system. The skeletal system, components and functions, so we're going to discuss both of those. The skeletal system consists of bones, cartilage, and joints. There's 206 bones, and it's divided into the axial skeleton. You can see that here in this figure shown in blue, and the appendicular skeleton shown in cream. And as we discussed before when we were discussing body regions, again, the appendicular region refers to the legs and arms, the appendages, whereas the axial body region refers to the head and the neck and the trunk. Okay, so the skeletal system provides support, obviously, for standing, walking, running, and it also provides protection for the internal organs that are housed within the skeleton. The skeletal system also stores minerals. It manufactures blood cells, or hematopoiesis, which is basically the production of blood cells, and that occurs in the bone marrow. And again, as we just learned, the bone marrow also contains stem cells. So there's 3 layers of bone. Okay, normally you just think of bone being bone. Well, there's actually 3 layers. There's the periosteum, as you can see in this figure. The periosteum, there's compact bone, which is kind of the outer border right here, and then this cancellous bone here in the center. All right, specifically, we're going to talk about alveolar bone, the bone that supports the teeth. It consists of both compact and cancellous bone. And these are radiographs here, and you can see this compact bone appears a lot more dense here. And then the cancellous bone is the bone here that you can see that has more of a trabecular pattern that looks a lot less dense on the x-ray. You can kind of see the darker areas are like the little spaces in between the bone there. So I'm going to show you some pictures here that may help you see a little bit better the difference between the 3 different types of bone, the periosteum, the compact, and the cancellous. Okay, so here is an example of a radiograph. Again, this is on the outside, you can kind of see, or inside, excuse me, you can see the cancellous bone. The compact bone forms the outer layer. So this is a picture of what this would look like in the mouth. Okay, you have the gum tissue or the gingiva on the outside. The next layer, when you peel back that gum tissue, you'll see the periosteum. Okay, that is a thin layer of whitish connective tissue, and this periosteum is critical for bone growth, for bone repair, for nutrition, and for elimination of waste. The outer layer of the periosteum contains nerves and blood vessels. The inner layer supplies cells such as osteoblasts. Those osteoblasts are responsible for bone formation. The periosteum, or this outer covering of bone, which is right underneath the gum tissue, it is anchored to the underlying bone by Sharpie's fibers. Okay, remember that, Sharpie's fibers anchor that periosteum to the underlying bone. Okay, so immediately below the periosteum is dense, rigid, compact bone. So you've got your gingiva here, you just gently peel that back and you see that periosteum. Now that periosteum is very tightly connected to that gum tissue, and then again to the bone by what? Sharpie's fibers. Very good. So you can see here the compact bone here that forms the outer layer of bone. It's very hard, very dense, and it's very, very strong. So again, on this x-ray, it's kind of hard to make out the compact bone, but again, if we go back to the previous slide, you can really see on the mandible here, that border of the mandible, it's a very dense, compact bone. The cancellous bone, on the other hand, as we mentioned, is found in the interior part of the bones. It's lighter in weight, it's not as strong as compact bone, and as I mentioned before, it's also called trabecular bone. The bony spicules, or the small pieces of bone in that cancellous bone, form a mesh of spaces, and that's within those spaces, that's where the bone marrow is formed. And again, it appears web-like on radiograph, so it's real easy to see this trabecular pattern is what we call it, or trabecular bone, or also called cancellous bone. And the bone marrow, which is within those spaces of the cancellous bone, that is where white blood cells are produced. Those white blood cells help fight infection, Red blood cells are also produced in the bone marrow. Those red blood cells are responsible for carrying oxygen. And then there's also platelets, and those platelets are important to help control or help stop bleeding. So other components of the skeletal system include cartilage, which is found where bones are joined together, and also joints. And joints can be either fibrous, cartilaginous, or synovial. The temporomandibular joint, or TMJ, is an example of a synovial joint. All right, so as far as disorders of the skeletal system, you've got arthritis, fracture, gout, osteomyelitis, osteoporosis. You can have a sprain. And if you will read in your textbook, it will go into much more detail about those specific disorders. All right, so that completes the skeletal system. Next, we'll discuss the muscular system. The muscular system is made up of over 600 muscles that work together to allow us to stand, walk, run, jump, and smile. Muscles are composed of muscle tissue, connective tissue, nerve tissue, and vascular tissue. All right, so as we discussed in Chapter 6, there's 3 different types of muscle tissue. The first being striated muscle, also called skeletal muscle. Again, it's responsible for voluntary movement of the arms and legs, for example. Smooth muscle, as we discussed before, does not have those striations visible under a microscope, so that's why we call it smooth muscle. And it's responsible, again, for the involuntary movements, such as digestion and found in some internal organs. And cardiac muscle is the muscle that makes up the wall of the heart and helps pump blood out of the heart. So what does muscle do? Again, when muscles contract, they become tighter, they become shorter and thicker. And then when the muscle relaxes, it returns to its original shape. Muscles are arranged in opposing pairs, so when one relaxes, the opposite muscle contracts, and that's what makes motion possible. And again, the disorders of the muscular system are listed in Table 7.4 in your book, and you can take a look at those. All right, so next we're going to discuss the cardiovascular system. The components of the cardiovascular system include the arteries, the veins, and the capillaries. It includes the heart, and it also includes the lymphatic system, which we're going to discuss in more detail later. The function of the cardiovascular system, it transports oxygen and nutrients to the body cells. It transports carbon dioxide and waste products from the body cells. And it's also responsible for transporting hormones and antibodies throughout the body. It also not only transports, but it also regulates. The cardiovascular system helps regulate body temperature, and it also helps maintain the chemical stability. And we'll discuss this in more detail later, but there's a huge relationship, or research has shown a big relationship between periodontal disease and cardiovascular disease. So we'll further explore that relationship later. Okay, so let's talk about the heart. So the heart's a hollow muscle that's located in the thoracic cavity between the lungs and above the diaphragm. As you can see here, it pumps 4,000 gallons of blood every single day. And it's about the size of a closed fist. That kind of gives you an idea of the size of your heart, and is surrounded by what we call the pericardium. And it's made up of 4 chambers. Those chambers you can see here. There's 2 atria and 2 ventricles, the right atrium, the left atrium, the right ventricle, and the left ventricle. The right side of the heart, as you can see here, pumps blood to the lungs. The left side of the heart pumps blood to the rest of the body. Now, each of the atria and the ventricle are separated by a valve, and you can see that right here. and that valve, what it does is it prevents the backflow of blood. So the tricuspid valve, as you can see right here, is on the right side of the heart, and it separates the right atrium from the right ventricle. The mitral valve, and it's called tricuspid because there's actually 3 leaves of that valve there. The mitral valve is also called the bicuspid valve because it has 2 leaves, and it separates the left atrium from the left ventricle. Okay, there are coronary arteries or coronary vessels that surround the heart, and that's actually what supplies the blood to the heart muscle itself. Okay, so the heart actually has to have blood supply to it for it to function. Okay, so here's an example on the outside of the heart of those coronary arteries and coronary veins that help supply blood to the heart muscle itself. So we're going to talk a little bit about how the blood actually flows through the heart. I said that before that the right side of the body pumps, the right side of the heart pumps the blood to the lungs where it's oxygenated and then goes back to the heart to the left side, which then pumps that oxygen-rich blood to the rest of the body. Okay, so in general, arteries take oxygenated blood away from the heart. So that one's easy to remember. Artery starts with an A and away starts with an A. So arteries take oxygenated blood away from the heart to the rest of the body. The veins, on the other hand, take oxygen-poor blood from the heart, from the body to the heart so that it can be oxygenated and then recirculated and carried away from the heart by arteries. And the capillaries form a system of microscopic vessels that connect the arteries and the veins. Okay, so again, let's talk a little bit about the specific blood flow through the heart. The superior vena cava, as you can see right here, and then there's the inferior vena cava right here. Those take blood, again, it's vena cava, so think of it as being venous. That takes blood from the body towards the heart. Okay, it takes it to the right atrium, which is right here, and it passes through the valve, the tricuspid valve, and goes to the right ventricle. Okay, and then that blood goes from the right ventricle to the lungs. Okay, and via the pulmonary artery. Okay, where in the lungs, that's where the blood is oxygenated, and then it goes back to the heart via the pulmonary veins. Okay, and again, I said typically the veins carry oxygen-poor blood, but this is one exception. Okay, the pulmonary veins take blood from the lungs back to the heart. Okay, so they're the only veins that carry oxygen-rich blood, the pulmonary veins. So the blood goes from the lungs through the pulmonary veins and enters the left atrium. Then it goes through from the left atrium. It passes through the mitral valve to the left ventricle. Then from the left ventricle, it goes through the aorta. You can see here, this is this huge aortic arch right here. From the aorta, it's the largest artery. Okay, and then from that aortic arch, you can see it branches off, has several branches here. And that, after it goes through the aorta, it's then pumped to all parts of the body through the different arteries. All right, so now that you know how the blood flows through the heart and the body, let's discuss the blood and the blood cells. So your body contains about 4 to 5 liters of blood. When your blood is drawn into a collection tube, like when you have blood work done, it's spun in a centrifuge in order to separate the blood into its different parts, okay, and it's separated into solid and liquid portions. So the solid part of the blood contains the red blood cells, the white blood cells, and the platelets. Those are all found in the same layer. The textbook is wrong because it lists the plasma as a solid, but it should say that the red blood cells, white blood cells, and platelets are solid parts or formed elements. Okay, so we've got our plasma, we've got our white blood cells, our red blood cells, white blood cells, and our red blood cells, and the platelets. A few of the disorders of the heart are listed in Table 7.4. Okay, so let's talk specifically about the plasma. It is the liquid portion of the blood. As you can see here, it's mostly water. It also contains proteins. The white blood cells, or has it labeled here as the leukocytes, those fight infection. And there's 5 major types of leukocytes, and each of those have a specific function in the immune response. The platelets, or the thrombocytes, are made in the bone marrow, and again, as we discussed previously, have a major role in blood clotting. The red blood cells, or erythrocytes, are also produced in the bone marrow, and they contain hemoglobin, which plays a major role in the transport of oxygen. So although all blood is made of the same basic elements, not all blood is alike. There are 4 common blood types. You've got A, B, AB, and O, and then each of these can either be positive or negative. The blood types basically are determined by the presence or the absence of certain antigens. Now, antigens are substances on those red blood cells that can trigger an immune response if they're foreign to the body. So, for example, in the case of a blood transfusion, it's important to know the blood type of the recipient so that you can make sure that the transfusion is safe and that it won't be rejected, so which could potentially cause death of the individual. So let's talk a little bit about blood typing. Someone with type O negative is considered a universal donor, which means they can give blood to anybody. Someone with AB positive is considered a universal recipient, meaning they can receive blood from anybody. So again, in the case of a transfusion, the blood type has to be matched. So, in addition to the blood type, the AB, or O, you have to know the Rh factor, and that is just another antigen which is located on the surface of those red blood cells in some people. And so you're either considered Rh factor positive or Rh factor negative, depending on the presence or the absence of those antigens on the surface of the red blood cells. So Rh factor is also an important consideration during pregnancy. If an Rh negative mother gives birth to an Rh positive baby, during the delivery, that blood is mixed and the mother can develop anti-Rh antibodies. If during the next pregnancy the fetus is also Rh positive, the fetus can develop a condition known as erythroblastosis fetalis, which is due to the presence of the mother's anti-Rh antibodies, which were formed during that first pregnancy because the mother was negative and the fetus was the first baby was positive, and so this can actually cause fetal death. And so in order to prevent this, the mothers that have Rh positive babies, they are given an injection of anti-Rh gamma globulin, which prevents the formation of those antibodies. And so it's important to know your blood type And it's also important, I'm going to give a little plug here, to donate blood. Every 2 seconds, somebody in the U.S. needs blood, whether it be due to a car accident or mothers that lose a lot of blood during the delivery of babies, or people that suffer natural disasters. There are lots of reasons why people need blood transfusions, and it only takes a few minutes to donate blood, and 1 pint of blood that you donate can save 3 lives. So there's my plug. Go donate some blood. So the next system that we're going to discuss is the lymphatic system. And the lymphatic system is made up of lymph vessels, lymph nodes, lymph fluid, and the lymphoid organs such as the tonsils and the spleen. All right, lymph fluid flows between cells and tissues, carrying substances from those cells and tissues back into the bloodstream via the lymph vessels. So the lymph vessels carry lymph fluid. Lymph nodes are located within the lymph vessels. They help fight infection, and I'm sure all of you have had a swollen lymph node at one time or another, and those become swollen and can even become tender during an acute infection. And that's because there are a large number of lymphocytes, or those cells, that actually are gathered within those lymph nodes to fight infection. And those lymphocytes are what produce the antibodies that help fight infection. And we'll go into further detail about antibodies and the immune response in chapter 19. So let's look at the different tonsils here. Tonsils and the spleen, as I mentioned, are 2 of the lymphoid organs. The spleen is the largest of the lymphoid organs and is located in the upper left quadrant of the abdomen. Let's go back here. You can see the spleen right there in purple. It's just below the diaphragm and directly behind the stomach. It produces lymphocytes and monocytes, which are, again, both important cells that help us prevent infection and also help us fight infection. The spleen also filters debris, and it stores red blood cells, and it also helps remove worn out blood cells. So the tonsils are a ring of lymphatic tissue that are located in the upper portions of the nose and throat. Typically, when you think of tonsils, you're typically referring to the palatine tonsils. Those are the tonsils that are located in the oropharynx, and those are the ones that are visible when you say ah. The nasopharyngeal tonsils, on the other hand, those are also called adenoids and are located in the nasopharynx. So typically when you hear somebody that has a tonsillectomy, usually they are they typically remove the palatine tonsils and the nasopharyngeal tonsils, or the tonsils and the adenoids is what they're often referred to. There are also lingual tonsils, which you can see here in this figure 712, are located on the back of the tongue. So the tonsils function to put lymphocytes, or those cells, into the lymph, which is that fluid, to destroy the microorganisms that invade the body. Okay, the tonsils can become infected and may even have to be removed. Okay, when a tonsillectomy is performed, usually all of those tonsils are removed, the palatine tonsils and the nasopharyngeal tonsils. And interestingly, the removal of those tonsils doesn't really seem to increase the susceptibility of the patient to infection. So, what purpose do they really service? That's kind of debatable. So why are the tonsils important to us as dental professionals? Well, several reasons. You may have seen tonsilloliths. Okay, as you can see here in this picture, here are the tonsils, and these white stones here are tonsilloliths, or tonsil stones. And your tonsils are filled with little nooks and crannies, as you can see here, where bacteria and other debris, such as dead cells and mucus, can become trapped in those little nooks and crannies, and that debris can calcify and form these little tonsilloliths or tonsil stones. These tend to form in people who have chronic inflammation or repeated incidences of tonsillitis. Now, again, let me go back. Let's learn a little bit of terminology here. When I talked about a tonsillectomy, that's the removal of the tonsil. Okay, so that ectomy refers to removal of. So you hear of an appendectomy, that's the removal of your appendix, or tonsillectomy, the removal of your tonsils. So when I also said people who have chronic inflammation or repeated incidences of tonsillitis tend to form more tonsillus or tonsil stones. That itis is on the end of the word tonsil, indicates inflammation of. Okay, so tonsillitis, inflammation of the tonsils. Gingivitis, inflammation of the gingiva. So these little tonsillitis, they can cause bad breath, or the correct term for bad breath is halitosis. They can also cause discomfort or pain when you swallow. They can kind of scratch the back of your throat. Sometimes these stones, you can remove them easily if they're easy to access, or if they become a persistent problem. Sometimes, a tonsillectomy is indicated. So that's one reason why tonsils are important to us. Tonsils are also important to us in the evaluation of a dental patient for possible obstructive sleep apnea. Now, this is important in kids and in adults as well. And so as dental professionals, we have the ability to evaluate these tonsils during our intraoral exam, and we can often alert the patient or the patient's parent. In the case of a child, we can alert them and their patient's physician to a possible problem. Chronically, as you can see here, these tonsils are huge, very enlarged, and they're actually what we call kissing tonsils here. They're touching in the center. This is the uvula in the back of the throat, and it's even being displaced by the tonsils here. Tonsils that are chronically enlarged, can contribute to obstructive sleep apnea. So during sleep, what happens is the muscles of the throat relax, and the constricted airway causes a drop in air pressure. So this combination causes the collapse of the throat, which causes the temporary inability to breathe, or what we call apnea. So after a few seconds of not breathing, the person wakes up, the muscle tone returns, the throat opens up, often with a gasp. Some of you that sleep with a person that has obstructive sleep apnea, you know what we're talking about here. Then the cycle often repeats itself many times in an hour. And so, as you can imagine, this results in the disruption of the normal sleep pattern. So this can have extreme consequences in both children and adults. It can not only, cause you to be very, very tired, but it also not keeps you from getting that restorative sleep, and can impact negatively many of the body systems, including the cardiovascular system. So we have the opportunity here to recognize the signs and the symptoms, and we have the responsibility to refer the patient to their physician. Now, lots of dentists work with sleep physicians to treat patients that have snoring, or even those with mild obstructive sleep apnea. And we can treat those patients many times with mild sleep apnea with an oral appliance therapy. However, many times patients that have severe sleep apnea oftentimes have to be treated with those CPAP type machines. All right, so the next system that we're going to discuss is the nervous system, and that is the system, the communication system of the body. I like to think of it as a computer. The central nervous system includes the brain and the spinal cord, which are the computer. I like to think of it as a computer. And the nervous system also contains the peripheral nervous system. So you have the central nervous system, brain and spinal cord, and then you have the peripheral nervous system, which are the nerves, and those are like the wires and the cables that carry the signals and the messages. Okay, so central nervous system, brain and spinal cord, peripheral system, nerves. The peripheral nervous system, actually let's talk for a second about this central nervous system, the brain and the spinal cord. The brain is composed of the cerebrum, the cerebellum, and the brainstem, which are responsible for regulating and coordinating different body functions. And then from the brain exits the spinal cord, which extends from the brainstem, right here, all the way down the body, and it carries the nerves to the limbs and to the lower part of the body. The peripheral nervous system consists of nerves that branch out from the brain and from the spinal cord, and there are two divisions of the peripheral nervous system, the autonomic nervous system and the somatic nervous system. The autonomic controls unconscious activities such as breathing, heart rate, your body temperature, your blood pressure, and your pupil size, whereas the somatic nervous system controls conscious activities. Table 7.6 lists several disorders of the nervous system, and there's a couple, if you'll read a little bit more in detail about those: trigeminal neuralgia or tic de la Rue, and Bell's palsy. Those are two disorders that affect nerves in the face, and those are probably two of the more common nervous system disorders that you will see as it relates to dentistry. All right, next up is the respiratory system. The term respiration means breathing or to breathe, and we'll discuss vital signs such as blood pressure and pulse in more detail later, and you'll learn specifically how to take those vital signs on patients. But respiration is another measurable vital sign. Basically just how many times respirations are measured by counting the number of times the chest rises and falls, and that's typically measured over 1 minute. The respiratory system, let's talk about a few of the functions of that. It's responsible for delivering oxygen to the cells and transporting carbon dioxide out of the body. So it's not only responsible for dealing with oxygen, but also the transport of carbon dioxide out of the body. All right, so the components of the respiratory system, as you can see here in this figure, air enters the body through the nostrils of the nose and passes through the nasal cavity. And the air in the nasal cavity is filtered by cilia, which are on the mucous membrane. That mucous membrane, it lines the nasal cavity. It also not only filters things that come in, the air that comes in, but it also, that nasal cavity also produces mucus, which helps moisten and warm the air. So after the nasal cavity, the air continues to the pharynx, as you can see right here. And the pharynx is also called the throat. Okay, the pharynx has three divisions. You've got, as you can see here, the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx is part of the pharynx that is located right behind the nose, and it's above the soft palate. The eustachian tube, which is in the middle ear, it leads from the middle ear and actually opens into the nasopharynx. The oropharynx is the part of the throat that you can see when looking into the mouth, okay, and that extends from the soft palate to the epiglottis, and then opens into the trachea and the esophagus. So the epiglottis is what covers over the trachea during swallowing to make sure that the food goes into the esophagus instead of the trachea. So what happens if that doesn't occur, if that epiglottis doesn't cover the trachea, that's what is also known as aspiration, when an object such as food, vomit, a small dental instrument, a tooth, fragments of a tooth, a filling or a crown, when that goes into the trachea, that's known as aspiration. And so that is why, clearly that is not a good day when that happens. So that is why we must take extra precaution to protect a patient's airway and to prevent this from happening. And there's several ways you can prevent this from happening. You can, small instruments that you're using in a patient's mouth, you can ligate those or tie floss around those, so that way if it does fall in, you've got a little safety line and you can pull that back out. You can also use a rubber dam, which we'll discuss definitely later, but that's just a piece of rubber that can fit over the teeth to prevent anything from going down the throat. You can also place gauze packs in the back part of the throat. Like, for example, when I'm taking a tooth out, I always put a piece of gauze covering the back of the mouth, so it almost acts like a catcher's mitt in case that tooth jumps out or any pieces of the tooth break off. There's not any going down the back of the throat and becoming aspirated by the patient. The laryngopharynx extends as a third part of the pharynx. That extends from the epiglottis, which again was that little covering that covers over the trachea during swallowing and prevents the food from going into the trachea, allows it to go into the esophagus. The laryngopharynx extends from that epiglottis to the larynx. The larynx is also known as the voice box, which that's where the vocal folds are located. Commonly, those vocal folds are known as vocal cords. After the larynx, the air then continues to the trachea, which extends from the neck into the chest. Okay, so you can see the larynx here, and then the trachea extends into the chest. And it's located just anterior to the esophagus, and you can feel that by palpating the outside of the front part of your neck, the anterior portion of your neck. And that trachea is held open by C-shaped cartilaginous rings. The trachea then divides into two branches or bronchi. Each bronchus, that's the singular of bronchi, each bronchus leads to a lung where it's divided into smaller branches. Okay, the smallest branches are called bronchioles, which you can see labeled here. Those bronchioles have alveoli at the terminal ends. Now, alveolus is the singular, and collection of alveolus or multiple are called alveoli. Okay, and the alveoli are grape-like little structures, as you can see here, and they have very thin walls, and the thin walls of those alveoli, as you can see here, have capillaries, and that network of capillaries, that's where the exchange of oxygen and carbon dioxide occurs. Table 7.7, you can look in your book, discusses several disorders of the respiratory system. All right, so next let's talk about the digestive system. The digestive system is responsible, of course, for breaking down food to provide the body with the energy and the nutrients, and the water, and the electrolytes that are necessary to sustain life. So food is taken into the mouth during ingestion. We're going to talk about the different components here. It's taken into the mouth. Once it's in the mouth, mastication, or that's the term for chewing, allows the food to be mixed with saliva. Now, your saliva contains an enzyme called salivary amylase, and that's what begins the breakdown of carbohydrates. Okay, the food is then goes through the pharynx, and again we talked about the three different types of the three different parts of the pharynx in the last slide. Goes through the pharynx. The epiglottis again covers the trachea, which allows the food to continue through the esophagus, which is just behind the trachea. And that's where peristalsis occurs. And peristalsis, that is the term for the movement of food through the esophagus to the stomach. So once it's in the stomach, the gastric acids continue the digestion of carbohydrates and begin breaking down protein. So the breakdown of carbohydrates begins actually in the mouth, and then the breakdown of proteins begins in the stomach. So nutrients from food passes through the lining of the stomach and the intestines into the bloodstream, and then throughout the rest of the body. So most of the absorption of nutrients occurs in the small intestine, which you see here. So directly after the stomach, the food goes into the small intestine, In the large intestine, that's where most of the excess water is absorbed. And then, of course, as food continues through the large intestine, the solid that's produced by the intestine, those are eliminated in feces. So whatever doesn't get reabsorbed to the body, that is eliminated. So not only in digestion do you have the mouth, the esophagus, and the stomach, but you also have the liver, the gallbladder, and the pancreas that are involved in digestion. Now, the liver is the largest of the internal organs and has many functions. In the context of digestion, it produces bile, and that bile is a fluid that helps in digestion and also absorption of nutrients. The bile is stored and it's concentrated in the gallbladder. So bile and digestive enzymes are also produced by the pancreas. They are emptied into the duodenum, which is part of the small intestine. Okay, so one of the important things that we're going to discuss here is relates to saliva, and that's where I mentioned that's where digestion, the beginning of digestion occurs of carbohydrates begins actually in the mouth, not in the stomach. So reduction of saliva or a change in the composition of saliva is a condition known as xerostomia. And that's very, very important to us as dentists. Reduced saliva, as you can imagine, as you may have experienced, can cause difficulties in tasting, chewing, swallowing, and speaking. And it can also increase the chance of developing dental decay, tooth sensitivity, and oral infections when you don't have that saliva in your mouth to begin the breakdown of food and help the food get washed away from the tooth surfaces. If that food just sits on the surfaces of the teeth, it's going to make you much more susceptible for developing dental decay or caries. And so that's one of a huge part of what we do is, patients that have xerostomia or dry mouth, there are lots of different things that we can do to help not only lubricate the patient's mouth, but also things that we can do to replenish that saliva to reduce the risk of dental decay, and that's something that we'll talk in detail about later. All right, so the next system that we're going to discuss is the endocrine system. The function of the endocrine system, it produces hormones that affect metabolism, that affect growth, and also development. And these hormones are secreted directly into the bloodstream, and they're secreted by ductless glands and tissues. So let's talk about the components. The endocrine glands include the thyroid gland, the parathyroid glands, the ovaries, the testes, the pituitary gland, the pancreas, and the adrenal medulla. These glands are scattered throughout the body, as you can see here on this figure, but they function together as one system. There are a few disorders of the endocrine system, and those are listed in Table 7-9. One of the most common endocrine disorders that you're going to encounter is diabetes mellitus, which can be either type 1 or type 2. Uncontrolled diabetes can negatively impact our patients' dental conditions, and it can put them at a greater risk for developing gum disease or periodontitis. Again, that itis, you notice, means the inflammation of, and that's referring to the inflammation of the periodontium or the structures that support the teeth. And diabetes can not only put them at risk for developing gum disease, it can make gum disease much harder to control if they have uncontrolled diabetes. And it can also decrease their ability to heal after a surgical procedure, after an extraction, for example. It can also put them at greater risk for failure of a dental implant because their body just does not heal as well. So, as a dental assistant, it's important to talk to your diabetic patients, first of all, to review their medical history with each patient at every appointment to make sure they haven't had any changes. But for these diabetic patients, it's important to ask them, have you checked your blood sugar today? Have you taken your medications as directed? Did you eat breakfast? Did you eat lunch? A lot of times, diabetic patients that are insulin dependent, they will take insulin, but then they don't eat. And so that can cause hypoglycemia, which is where they have low blood sugar. So it's really important that you recognize and know the signs and the symptoms of hyperglycemia, which is high blood sugar, and hypoglycemia, which is low blood sugar. Now, we're going to discuss that in further detail as far as how you recognize those and what we can do to treat those conditions when we discuss dental office emergencies. All right, so let's move on to the urinary system. The urinary system is also known as the excretory system, and it functions to maintain the proper fluid volume and composition of bodily fluids. Okay, waste products can leave the body in the form of urine, and then those needed substances are returned to the blood. So the components of the urinary system, the kidneys, filter large amounts of blood. They filter more than 2 pints every single minute. And they do that in order to remove waste from the blood. These waste products are carried away through the urine, the urine is formed in the kidneys, and the urine flows from the kidneys through the ureters. Here you have a right ureter and a left ureter, if we're looking at the patient on. And then travels from the ureters to the bladder, where it is stored until it is eliminated through the body, or from the body through the the urethra during urination. So several disorders of the urinary system are listed in Table 710 in your book. So you can imagine somebody who has kidney disease or who has limited kidney function, that can greatly influence and negatively affect their ability to filter waste. Again, if you're filtering more than 2 pints of blood every single minute, if your kidneys aren't working well, then you're not able to do that, and you're not able to eliminate or remove those waste products from the blood. So kidney disease specifically occurs when the nephrons, those are the tiny structures within the kidney that actually do the filtering of the blood. When those nephrons get damaged, that decreases the kidney's ability to filter the blood. And so those nephrons can be damaged by diabetes. When diabetes is not controlled, it can cause renal failure or kidney failure. Hypertension or high blood pressure, that can also cause destruction or disease and damage of those nephrons and can cause kidney or renal failure. Also, there are some hereditary or genetic factors that can cause kidney disease as well. All right, so next we're going to talk about the integumentary system. The integumentary system consists of the skin, which is the body's largest organ. Again, we talked when we were discussing the digestive system, the liver is actually the largest internal organ, but the skin is actually the body's largest organ. Okay, of course it's external, and it's the body's first line of defense when it comes to fighting against disease. So it also helps function to regulate body temperature. It provides a barrier that prevents bacteria from entering the body. It excretes liquids and salts in the form of sweat. It provides sensitivity to touch. And it also uses the UV rays from the sun to convert chemicals into vitamin D, and that vitamin D assists in the absorption of calcium. So what are the components? The components that the skin is composed of different layers, and it includes the outer layer, as you can see here in this figure, or the epidermis, and it does not have its own blood supply. So it is reliant completely on the underlying tissue here which is the dermis. The epidermis has melanin, which is produced there, and that's what determines our skin color. Now, the dermis, which lies immediately underneath the epidermis, contains many nerve endings and receptors that allow for the detection of touch, temperature, and pain. So that's what allows us to have sensation. The final layer underneath that dermis is the subcutaneous tissue, and that final layer is the subcutaneous fat. And that's a loose layer of connective tissue that is what anchors the skin to the underlying organs, which provide insulation and cushioning. So just as we saw bone had multiple layers, skin also has multiple layers. And the skin also has appendages. Those include hair, which you can kind of see here, originating in the dermis and going through the epidermis. It also includes, the skin also has appendages, which also include nails and glands also. Several disorders of the integumentary system are listed in Table 711. Now, Figure 719 shows photographs of the 3 most common forms of skin cancer. Now again, part of our examination of a patient includes a head and neck evaluation. We're not just looking inside the mouth. We also want to look at the entire head and neck region so that we can alert the patient to any suspicious areas. Many times patients see their dentist at least twice a year to have their teeth cleaned, and so a lot of times that's a lot more than they actually see their physician. And so we have a responsibility, to notify the patient of those suspicious areas and to encourage the patient to see their physician or their dermatologist for evaluation of those suspicious areas and for biopsy. Here in this picture, the 3 most common forms of skin cancer are squamous cell, which you can see in the first figure here in A. In B, that's an example of what a basal cell could look like, and obviously these are pretty advanced forms of skin cancer. And the third is melanoma. Malignant melanoma is oftentimes the most difficult to treat and can become the most fatal of the 3 types of skin cancer. All right, the next system that we will talk about is the reproductive system. The male and female reproductive system. It consists of external and internal genitalia. Fertility, or the normal function of the female reproductive system, begins at puberty with the onset of menstruation and ends at menopause. Now, Table 712 describes several disorders of the reproductive system. The male reproductive system consists of organs that serve as part of both the urinary tract and the reproductive system. There are certain disorders may interfere with the function of either system or with both systems, and a few of those disorders are listed in Table 713. Now, a couple points of application here. We're not going to spend a whole lot of time discussing the reproductive system, but one thing to consider is oral contraceptives. It's important to remember and that antibiotics, and we're prescribing antibiotics for our patients for oral infections. So it's important to remember that antibiotics can actually affect the efficacy of those oral contraceptives. So it's important to remind patients that are taking oral contraceptives to use another method of contraception while taking those antibiotics, and really for the remainder of that cycle. So again, it's important to know your patient, to review their medical history, to know the conditions, their pre-existing conditions, to know also what medications they're taking, so that you will know if we're going to prescribe an antibiotic for the patient, that we give them that heads up, that warning of the interaction between oral contraceptives and antibiotics. Another thing to consider here is pregnancy. During dental treatment, during pregnancy, dental treatment is safe and necessary. There are a lot of hormone changes during pregnancy, and those changes can increase a patient's risk for developing gingivitis, which is the inflammation of the gingiva, or periodontitis, inflammation of the periodontium. And that periodontal disease is actually another term for gum disease, and that has been linked to preterm labor and also low birth weight. So it's very important that that patients who are pregnant or considering pregnancy have a healthy dentition. During the first trimester, the organs and the body systems of that developing baby are developing, and so the safest time to provide dental treatment during pregnancy is actually during the second trimester, when that fetus, all the organs and the body systems are finished forming. But during that second trimester, they're actually just undergoing growth and maturation. So it's easiest and best to treat during that second trimester. During the third trimester, it can be difficult for the patient to sit comfortably in the chair. So typically that second trimester is best. Now, special considerations have to be made when you're giving local anesthesia and also prescribing certain things such as antibiotics and pain medication. We have to make special considerations for those patients so that we know which types of antibiotics and pain medications and local anesthetics are safe for the mom and for the baby. So ideally, any elective treatment really should be delayed until after the delivery of the baby. So, anything that's not medically necessary should be delayed. However, dental cleanings, preventive care, those are great things to have done while during pregnancy to keep the gingival health at its best. Now, in an emergency situation, of course, there are going to be times when, you have no choice. In an emergency situation such as, tooth pain or a dental abscess, if the patient has swelling, an x-ray or radiograph may be required. And so, only the necessary radiographs should be taken during pregnancy, and that's, typically taken when the patient is double shielded, meaning there's a lead apron covering both the front and the back of the patient. And many times if I'm treating a patient during pregnancy, I will often obtain medical clearance from the patient's OBGYN. That's just a letter stating from the OBGYN stating that the patient is having a healthy pregnancy and that they are able to have dental treatment done. And many times the OBGYN will give us specific restrictions regarding medications for that patient. So it's important that we communicate with that patient's physician, and many times as a dental assistant you'll be asked to help us potentially have the patient sign a release form so that we can send a medical clearance, for example, to that patient's physician, and the patient's physician has legal rights from that patient to give us information regarding that patient's care. All right, so as I almost spoiled the picture a minute ago, here is obviously a hippopotamus, again, that I saw during my safari in the Masai Mara. So here is our signal. Hopefully you're not yawning as wide as this hippopotamus is here, but it is time for another break. All right, so in Chapter 8, we're going to discuss oral embryology and histology. So embryology is the study of prenatal development, which are the stages of development before birth. Histology is the study of the structure and function of the tissues on a microscopic level. So I'm sure you're wondering, why do I, as a dental assistant, need to learn about embryology and histology? So just as we discussed in the last lecture, in the first 2 chapters of this lecture, you're developing a foundation, which is going to help you understand the problems that can occur with these structures. So you're going to be directly involved with the procedures to correct some of these problems. And so when you understand the how and the why, that's when it's going to transform your job into a career. And that is much more fulfilling and rewarding when you are a part of that team that is making oftentimes life-changing, producing life-changing results for these patients. All right, so embryology, pregnancy begins with fertilization of the ovum with the sperm. Okay, the average gestation period from fertilization to birth is 40 weeks, which is counted from the first day of the last menstrual period. However, in embryology, the developmental age is based on the date of fertilization, and that usually occurs 2 weeks after the last menstrual period. So let's talk a little bit about prenatal development. That consists of 3 different distinct periods. Okay, we've got pre-implantation, which occurs during the first week. An egg or an ovum is another name for an egg. An ovum has 23 chromosomes, and again, it is fertilized by sperm, which also contains 23 chromosomes. So a zygote is formed. You can see that here from the combination when that ovum is fertilized by the sperm, and the zygote has 46 chromosomes. So the 23 chromosomes from the ovum, the 23 chromosomes from the sperm form the zygote that has a total of 46 chromosomes. Now, the cells that are within that zygote begin to divide, continue dividing and dividing and dividing until a blastocyst is formed. Now, that blastocyst is actually what then implants in the uterus, and then development continues. So the second phase, that's pre-implantation. So then once that blastocyst implants in the uterus, that is then known as the embryonic period. And that begins the second week and extends all the way until the 8th week. This period is the most critical time because during these weeks, development begins in all of the major structures and organs of the body as the cells begin to proliferate, differentiate, and integrate. So therefore, during this time, this embryo is most vulnerable to malformations caused by things like radiation, viruses, and drugs. And so again, going back to what we just discussed in the reproductive system in the last chapter, this is why we really like to avoid unnecessary dental treatment in the first trimester, because all of these body systems and organs are beginning development. So the third period is the fetal development, and that begins with the 9th week, and that lasts until birth. All right, so during the 3rd week of development, the cells of the embryo form 3 primary embryonic layers, okay? And those are as you can see here in this figure, the ectoderm, the mesoderm, and the endoderm. Now, the cells within each layer multiply and differentiate into specialized cells that are needed to form the organs and the tissues of the body. So you can see that the brain develops from the ectoderm, the heart develops from the mesoderm, and the digestive system develops from the endoderm. So it's interesting to note that while the enamel, or the outer covering of the teeth, we're going to go into more detail about the different parts of the teeth later, but when that's formed from the ectoderm, but the other parts of the tooth, the remainder of the tissues found in the tooth, the dentin, which is just under the enamel, and then the pulp, which is in the center of the tooth, which is the nerve of the tooth, and the cementum, which forms the root structure of the tooth, those are all formed in the mesoderm. So again, the enamel is formed from the ectoderm, while the rest of the tooth is formed from the mesoderm. So again, our body is incredibly complex, and it's very, very fascinating. So the face and its related tissues begin to form during the 4th week of prenatal development and are derived from structures known as the branchial arches. All right, so the first branchial arch, also known as the mandibular arch, forms the bones, the muscles, and the nerves of the face, forms the lower lip, the muscles of mastication, and the anterior portion of the alveolar process of the mandible. Now, the alveolar process, again, is what describes that bone that contains the teeth. Okay, and so here's a picture of the first branchial arch. All right, so the formation of the hard and soft palates begins during the 5th week of prenatal development. First, with the formation of the primary palate and then formation of the secondary palate. The third stage is the fusion of the primary and secondary palates, which occurs during the 9th week, but it's usually not completed until the 12th week. And so, as you can see here, the fusion of those, that's what makes that Y-shaped pattern here that you see on the roof of the mouth, which is visible in infants. Okay, but as those bones continue to fuse, that Y shape is no longer visible. Now you can probably use your tongue to feel the midline of your hard palate, and that's right where that suture fused, and that is called the median palatine suture. So any disruption in the fusion of these palates can cause a cleft lip or a cleft palate. So basically it's just when did that disruption occur as to what forms. Was it a complete cleft palate and cleft lip, or just a cleft lip? So facial development, let's talk, occurs primarily between, as we said, between the 5th and the 8th weeks. At 1 month, the forehead is the dominant feature. And at 2 months, rapid growth of the nose and upper jaw occurs, and the lower jaw appears to lag behind. At 4 months, the hard and soft palates are differentiated, and the formation of the primary dentition, or the baby teeth, has begun. Okay, during the last trimester, fat is deposited in the cheeks in what is known as the sucking pads. Now these give the healthy full-term fetus that characteristic round face. So let's talk a little bit about tooth development. Let's go back, tooth development there. At 5 to 6 weeks of embryo development, the teeth began to form in the anterior mandible region first. Okay, so 5 to 6 weeks of embryo development, teeth begin to form in the anterior mandibular region. They're followed by the anterior maxillary teeth. So your lower teeth form first, then the upper front teeth second, then the posterior teeth of both the maxilla and the mandible, the upper and the lower jaw form. Now by 17 weeks, all of the primary teeth are developed, and then the development of the permanent dentition actually begins. So even in utero, the permanent teeth have begun to form. So at birth, there are typically 44 teeth in various stages of development. You've got 20 primary teeth, and then 24 of the permanent teeth are in development at that point. So enamel formation during this time begins to form and occurs on all primary teeth, and it's beginning to occur on the permanent first molars. So let's talk about some disturbances in tooth development that can occur at any stage of development of the tooth and can create a wide variety of anomalies. There's 2 major categories of factors that can adversely affect the development of teeth, and they are genetic factors and environmental factors. Now, genetic factors most often involve tooth size and jaw size. So, for example, if a child inherits large teeth from one parent and a small jaw from the other, or small teeth and a large jaw, this can create a malocclusion. So, if the patient has small jaws but big teeth, a lot of times what can happen is they end up having, a lot of crowding, and then may end up having to have teeth extracted during orthodontic treatment. If they have large jaws and small teeth, it can result in a patient that has a lot of spaces between their teeth. And genetic factors can also include congenitally missing teeth, where certain permanent teeth never form. A lot of times you'll see the patient's lateral incisors. These are the central incisors, the teeth directly on either side of the centrals. Those are known as lateral incisors, and you'll learn all about those later on, the specific names for the teeth. But these lateral incisors, a lot of times you'll find those missing altogether. Sometimes one will be missing, or sometimes both will be missing. And so, it's important during, as a child, that we take radiographs of children and count the teeth so that we know, are there any teeth that are congenitally missing, so that as that child grows, we know how we're going to replace those teeth. Sometimes wisdom teeth, the third molars, never form. Sometimes extra teeth form. Sometimes another genetic factor we oftentimes see is what we call a peg lateral. Now this is an example of a peg lateral. Both of these are peg laterals. This one is a little more peg shaped, but you can see the maxillary lateral incisors are often peg shaped, and many times we can restore those to a normal size using crowns or veneers or even composite material. Now, certain environmental factors can also cause developmental disturbances as the teeth are forming. Those factors can be teratogens, which can cause, those are several different types of teratogens. These are adverse environmental influences that can include infections. So as those teeth are developing, potentially a systemic or infection of the body can cause disturbances in tooth development. Certain drugs that are ingested either by the mother or by the child can cause problems. Also, exposure to radiation can cause issues as well. So in particular, we know that the antibiotic tetracycline, if it's taken during pregnancy, can result in this yellow, gray, brown stain on the primary teeth, and then it can also cause staining in the permanent dentition if it's given to children. So many older adults, middle-aged older adults, you will see tetracycline staining. And I have a picture here of a patient. This is a patient that I actually treated. This is probably the worst case of tetracycline that I have seen. This child was given tetracycline as a child before we knew the dental consequences of it, and it's an intrinsic stain, which means it's not like coffee stain or tea stain on teeth that can be polished off. This is actually an intrinsic stain that cannot be removed, and it can be very, very difficult, if not impossible, to whiten the teeth with traditional tooth whitening options. So sometimes, a patient's only option may be veneers or crowns to actually cover those teeth, just to cover up the staining. Table 8.1 describes some other developmental disturbances that can occur at different stages of development. All right, so in addition to tooth development, the facial development continues after birth and changes considerably from the newborn to the adult. So you can look at photos of yourself as you grow, and you'll notice the same changes in contour as are noted on this slide. Specifically note that the forehead and the maxilla, or the upper jaw, and the mandible, the lower jaw, as those bones grow and change shape, the facial contours change shape. So you can notice that here. Bone growth. Let's talk about that. Bone growth involves deposition or the laying down of bone and of the deposition of new bone in some areas, and the resorption of existing bone in other areas. Both of those, bone deposition and bone resorption. Bone deposition occurs by osteoblasts. Bone resorption occurs by osteoclasts. I always remember that by osteoblast, bone forms. Osteoclasts, the C, I always think of that as osteoclasts, resorbing the bone or chewing up the bone. Chew starts with a C. Osteoclasts, there's a C in osteoclasts. So, for example, new bone is formed after a tooth is extracted. So you take a tooth out, And initially you have that socket where the tooth root used to be, and new bone will eventually fill in that socket. So you have osteoblasts and osteoclasts that are responsible for the formation of that new bone that fills in where the tooth used to be. Bone resorption can occur in cases of periodontal disease, where the bone actually resorbs, or the bone grows away from the teeth. All right, so before we talk about the life cycle of a tooth, let's look at the components of a tooth. Okay, seeing the finished product will kind of help you understand the process of formation. So here we've got the crown of the tooth, the root of the tooth, and then the internal structures of the tooth. So we're going to go specifically to discuss all those, but I think it kind of helps to have a big picture of what the tooth looks like, the finished product, before we actually discuss how each of those components form. So in the crown of the tooth, you've got the enamel, which surrounds the outside of the tooth. That's that really hard white area that you see on your teeth, covering your teeth. Underneath that, you have the dentin, that layer underneath the enamel. You also have a layer called cementum, and that is the material that actually surrounds the root of the tooth. The internal portion of the tooth, you have the pulp, or the pulp cavity, and that's where the nerves and the blood vessels are located. You also have the periodontal ligament that surrounds the tooth, and then finally you have the bone that surrounds that periodontal ligament. Now, on a radiograph, you can see the different structures of the tooth. You can see the enamel. It appears more radiopaque, or more dense here. Then you have the enamel, which is not quite as dense, so it doesn't show up as white or as radiopaque on the x-ray. And then you have the pulp. So the pulp is actually the pulp cavity is actually hollow, and it contains that nerve tissue, and so it shows up as radiolucent on the x-ray, or you see a little darker here. The x-ray waves are able to penetrate that tooth, and so because there's no real dense tissue here, it's nerve tissue, the x-rays penetrate through that a lot easier, so it shows up as radiolucent on the x-ray. So here in this picture, this x-ray radiograph, you see a first molar, a mandibular first molar, and then directly in front of that you see a second premolar, or bicuspid, forming, and on top of that, that is a baby tooth, or a primary tooth, a primary 2-year molar that the roots have been resorbed, and this permanent tooth is about to erupt and cause the exfoliation, or the loss of the baby tooth. All right, so let's talk about the life cycle of a tooth. All right, so the process of tooth formation is called odontogenesis, and it's divided into 3 primary periods. Okay, we have growth, calcification, and eruption. Now, the growth periods are divided into 3 stages: the bud, cap, and bell stage. The bud stage is also known as initiation, and this is where the formation of the tooth begins. Okay, as you can see in that picture. The cap stage, or proliferation, is where the cells of the developing tooth increase. The bell stage, or histodifferentiation, is where the different tissues of the tooth form and its shape is actually established. Okay, the book goes into much more detail about each of those stages. Now, calcification occurs when the structures formed during the growth stage are hardened by the deposition of calcium and other mineral salts. The enamel is formed layer by layer, and it's formed by cells known as ameloblasts, and those work outward from the dentino-enamel junction. Okay, and that dentino-enamel junction is where the dentin and the enamel where they come together. And so those the ameloblasts which form the enamel work outward from that DEJ to the DEJ from the dentin outward towards the top of the tooth and then spread downward over its sides. All right. So as the calcification process continues, you have pits and fissures that are formed. Okay, so you can kind of see the pits that are formed here and then the fissures that are formed here. And here's a sealant that's actually in the pits and fissures. So premolars, which are also called bicuspids, and molars have cusps or lobes that are covered with enamel. And so you can see here, this is a first molar, a second molar, a second premolar here. Those cusps eventually fuse together or coalesce. It's another word for fusing together to form a solid enamel covering for the occlusal surface of the tooth. And that occlusal surface, and we'll go into more detail about the specific directions and words that we use to describe teeth, but the occlusal surface is the chewing portion of the tooth. Now, pits and fissures may be formed during this process as that enamel coalesces. Now, a fissure is a fault along a developmental groove on the occlusal surface or the biting surface, and that fissure is caused by the incomplete or the imperfect joining of the lobes. You can see the lobes. This is the lobe here, a lobe here, a lobe here, and a lobe here. That fissure is an incomplete or imperfect joining of those lobes during tooth formation. Now, a pit results when two developmental grooves cross each other, and they form a deep area. And oftentimes, that deep area, such as right there, or even like here on the side of the tooth, here and here, those areas are so deep, oftentimes the single bristle of a toothbrush cannot even get in that little pit to clean it. And so the enamel is usually very thin in this area and it's hard to clean. So as you can imagine, this is a very easy place for decay or a cavity to start. And so this is the reason why we use dental sealants. Okay, as you can see, going from the previous picture where you have these unsealed pits and fissures, we'll use sealants to cover over those pits and the fissures here. And ideally, the sealants would be placed as soon as that premolar and as soon as the molar erupt to eliminate the bacteria getting down into those pits and fissures, and you don't want to seal over that. So many times as soon as those teeth are erupted into the mouth, we will clean out those grooves and the pits and then place those sealants to prevent food and bacteria from getting trapped and therefore causing tooth decay. So now that we know how teeth form, let's discuss how they erupt or move into a functional position within the oral cavity. So eruption of the primary and permanent dentition take place in a chronological or specific order. Now, sometimes this order can be different and among different individuals, but for the most part, it takes place in a certain order. Teeth typically, are pretty predictable in the way that they erupt. So as the tooth actively erupts and moves through the gingival tissue, you have an inflammatory response which occurs, and that can cause tenderness and swelling of tissues. And as you know, that's what we call teething, and so there can be a lot of discomfort associated with teething. So I want to refer you to these figures, figure 8 and 11. I'm not going to spend a lot of time going over each individual picture, but I want you to spend some time looking, kind of getting a feel for the eruption patterns of both primary and permanent teeth. All right, so as the permanent, or another word for the permanent teeth is the succedaneous teeth, as those teeth develop and erupt, the primary teeth become loose, as you saw in that radiograph. As those roots are resorbed, the primary tooth becomes loose and it's lost through the process known as exfoliation. Now, again, this occurs when the osteoclasts cause resorption of the root of the baby tooth or the primary tooth. It begins at the apex or the bottom of the root and continues up towards the crown of the tooth. And eventually the tooth is lost because it just doesn't have any support. The roots which previously held the tooth in the alveolar bone are now gone. Also, you have that permanent tooth erupting. So it's important that we evaluate the exfoliation of a child's primary teeth and the eruption of their permanent dentition. And it's important, if there's any problems, that we note that an orthodontic consultation is advised to determine if early intervention is necessary. Okay, so again, this is just that radiograph that shows us. This is a primary tooth. You can see this maxillary premolar is in the process of erupting. This primary tooth has pretty well developed roots still, whereas this mandibular primary second molar, the roots are pretty well resorbed, so we know it's not going to be long before this tooth is exfoliated. And again, this is a panoramic x-ray which shows all of the teeth at one time, and it's important that we take panoramic x-rays, radiographs on children to determine, to be able, as I said before, to count the teeth. Let's see if there are any teeth that are missing. Make sure the patient has all the teeth that they're supposed to have. You can kind of see the teeth as they're the permanent teeth here as they are forming. This shows newly erupted permanent first molar. This is a second molar that's in the process of formation. You can see here the primary teeth and the anterior, maxillary anterior primary teeth. The roots are resorbing, so it's not going to be long before those permanent teeth erupt and the primary teeth are exfoliated. Again, here's a cool picture of a skeleton which shows the unexfoliated primary molars, which you can see here, and you can see those unerupted permanent premolars that are forming. It's important to note that there are no primary teeth in the position of our first, second, and third molars. Okay, so the primary teeth stop at where our permanent premolars are. Okay, so there's no baby teeth where the molars, where our permanent molars will erupt. All right, so now that you have an understanding of oral embryology, or the stages of development, let's further your understanding by discussing the histology, or the structure and the function of the tissues on a microscopic level. So we're going to discuss the anatomic parts and the histology of the teeth. We briefly discussed that earlier. We're going to discuss the supporting structures and the oral mucosa which surrounds the teeth and lines the mouth. Okay, so each tooth consists of a crown and one or more roots, depending on the type of tooth. And again, we'll discuss specific tooth morphology in more detail in Chapter 11, which will be in Module 3. So in the crown, the dentin is covered by enamel. In the root, the dentin is covered by cementum. The cemento-enamel junction, or the CEJ, is the location where the enamel of the crown and the cementum of the root meet. So you can see that right here. Okay, and I'll show you that here clinically in a photograph. Now let's go back one second before we do that. The pulp, again, as I discussed before, is in the center of the tooth, and it's surrounded by the dentin. The pulp houses the nerve tissue and the blood supply of the tooth. So we can discuss the crown, describe the crown in a little more specific way. For example, the portion of the tooth that is covered with enamel is known as the anatomical crown. Okay, so you can see here in this photo, the anatomical crown is just the portion that has the enamel, whereas the clinical crown is any portion of the tooth that's visible in the mouth. So the clinical crown may have enamel, but it may also contain cementum, which is the root surface of that tooth here, whereas when we speak of the anatomical crown, that is just talking about the part of the tooth that is covered with enamel. Now, the height of the clinical crown, it depends on the level of the gingiva or the gum tissue. So again, the clinical crown is going to be shorter when the tooth has not fully erupted, and the clinical crown is going to be longer in this case, for example, where recession is present or where the gum tissue has receded from the tooth. All right, so those are the parts of the crown. The root is the part of the tooth that is normally embedded in the alveolar process or the alveolar bone, and it's covered with cementum, as you can see here. So again, where the enamel and the cementum meet, that is known as the cemento-enamel junction. Now, depending on the type of tooth, the root may have 1, 2, or 3 branches. Typically, the area that is where the root divides, so in the case of this is a mandibular or lower molar, those typically have 2 roots. The area where the tooth divides into its 2 roots, this area right here, is known as the furcation. So a bifurcated root means that the tooth is divided into 2 roots, whereas a trifurcation means that the tooth is divided into 3 roots. So many times a maxillary or an upper molar has 3 roots, or it's trifurcated, whereas a mandibular molar has 2 roots, or it's bifurcated. There can be exceptions, which we'll talk about when we discuss tooth morphology. Now, the end of the root is known as the apex. And so apex is the singular term, and if we're going to talk about a tooth that has 2 roots, we're going to talk about these areas, the apex of the roots, being the apices. Okay, anything that surrounds the apex of the tooth is described as periapical, or periapical, around the root. So a radiograph that shows the area around the end of the tooth, the root of the tooth, or the apex of the tooth, is known as a periapical radiograph. So again, I showed you before a panoramic x-ray or radiograph, which showed the maxilla, the mandible, the teeth, the sinuses. A periapical radiograph shows the apex or the root of the tooth, and it's important when we're taking radiographs, when the dentist asks for a periapical radiograph, it's important that we capture in that radiograph the entire apices of the root or the entire apex of the root, because oftentimes when a tooth becomes infected, when the nerve, the pulp becomes infected, we'll see that infection in the bone at the apex of the tooth. So it's very important that you capture the entire apex of the root in that x-ray. So as we said earlier, excuse me, the enamel covers the anatomical crown of the tooth. The enamel is the hardest material in the human body, and it allows us to crush, grind, and chew our food. That enamel covers the underlying dentin, which is much softer. The enamel is translucent, and it ranges in color from yellow to grayish white. And again, as we said before, it's formed by ameloblasts. And it contains 96 to 99% inorganic matter. So most of it is hydroxyapatite, which is calcium. Most consists primarily of calcium. So the other 1% to 4% is the organic matrix, which consists of water, proteins, and glycoproteins. Now, microscopically, the enamel is composed of millions of calcified enamel prisms known as enamel rods, and you can see that here in this figure. Those enamel rods extend from the surface of the tooth to the DEJ, and again, that dentino-enamel junction is where the enamel and the dentin meet. And if you look at a cross section of the enamel, the prisms resemble a handful of drinking straws, like you see here. So during tooth whitening, the stained components are typically found between the enamel rods. And this area whitens and becomes more opaque, so that the tooth becomes then more becomes and appears whiter and brighter. So the enamel is very hard, and it's able to withstand crushing forces to about 100,000 pounds per square inch. So it's even though it's very strong and hard and able to withstand crushing forces, it's also very brittle, which can cause another property which can cause it to fracture or chip or shear easily. So the compression strength or the crushing force is actually very, very strong, but again, it can be very brittle, which can cause it to fracture and chip. So the next thing that we're going to talk about is the dentin, which is underneath the enamel. That's what makes up the main portion of the tooth structure and extends almost the entire length of the tooth. As you can see here, the dentin here is in yellow, and it's covered by enamel on the crown and by cementum on the root. And in primary teeth, it's very, very light yellow. And in permanent teeth, it is also light yellow, but it can darken with age. So when you're preparing a tooth, that white outer covering of enamel, and then when you go through that enamel, you'll know that you're in dentin because of the difference of color. It's also softer, so it's going to feel a little bit different. Then the dentin is actually harder than bone and cementum, but it's not as hard as that enamel. And it's composed of 70% inorganic material, so it's has less inorganic material than enamel, but it has more organic material than enamel. It has about 30% organic material and water. And so the fact that it has a much higher organic content, or softer, allows it to have more decay, allows decay or caries to spread much more quickly in the dentin than in enamel. So the dentin is formed by the odontoblast. Remember, the enamel was formed by the ameloblast. The dentin is formed by the odontoblast, and it begins at the DEJ and continues toward the pulp chamber. So remember, the enamel formed from the DEJ outward. The dentin forms at the DEJ and continues inward towards the pulp chamber, which houses the nerve or the pulp. The dentin is composed of dentinal tubules, which contain dentinal fibers. And the dentinal fibers end in a branching network at the junction with the enamel or the cementum, depending on which direction you're going. And these dentinal fibers can transmit pain stimuli. So unlike enamel, dentin is actually capable of continued growth and repair. So there's 3 different types of dentin. The first is primary dentin, which is formed before the tooth erupts, and this is what forms the majority of the tooth. Now, secondary dentin begins formation after the tooth is erupted and continues at a very slow rate throughout the life of the tooth. So oftentimes, if you look at, compare the tooth of a young adult, for example, with an older adult, you'll notice that pulp chamber actually appears smaller on an older adult, because as that person matures, as that tooth continues to lay down secondary dentin, it causes that pulp chamber to get smaller or even calcify. Tertiary dentin, or also known as reparative dentin, is formed in response to irritation, such as decay, and appears as a localized deposit on the wall of the pulp chamber. So next, let's talk about cementum, which covers the root surface of the tooth. It covers the dentin, and it joins the enamel on the outside of the tooth at the CEJ, or the cemento-enamel junction. that cementum is light yellow. Again, you can see it right here. This is the CEJ. This is the junction of the enamel and the cementum. The cementum is light yellow. It's usually lighter than dentin, but it's not as white as the enamel, so it's really easy to distinguish here the root surface of the tooth that's covered by cementum from the anatomical crown of the tooth that's covered by enamel. Now, the cementum is formed by cementoblasts. Primary cementum is formed as the root develops, and then the secondary cementum continues to form on the apical half of the root, or the this would be the apical half of the root after the tooth has reached functional occlusion, or after it's completely erupted into the mouth, you're chewing on it, the secondary cementum forms on the apical half of the root. We would refer to this portion of the root, the upper half of the root, as the coronal portion of the root, as in it's closer to the crown of the tooth, whereas this lower half of the root would be the apical portion of the root because it's closer to the apex of the root. All right, so the final part of the tooth that we'll talk about is the pulp of the tooth, and it's found in the center of the tooth. Again, it's made up of blood vessels and nerves that enter the pulp chamber through what's called the apical foramen. There's a little hole at the end of the apex of the tooth here, and that's where the blood supply and the nerves enter the pulp chamber. The blood supply is derived from branches of the dental arteries and also from the periodontal ligament, which forms around the root of the tooth, right here, this little thin ligament here. Okay, the coronal pulp lies within the crown portion of the tooth, and it includes the pulp horns, which you see here and here, and those project towards the cusp tips. The cusp tips are here and here, or here. The pulp horn projects towards the cusp tips in a molar or towards the incisal edge in an anterior tooth. The radicular pulp is located more apically, or again toward the apex. So as caries progresses, it begins on the enamel, progresses through the enamel into the dentin. Let's go to this next picture here. You can see on this, you can see the pulp horn a little bit better in this picture. You can also have little accessory canals that come off of the pulp, and then you can see that apical foramen there. So as decay progresses from the enamel, it goes through the enamel, through the dentin, and again we said it travels quicker through the dentin than it did the enamel, because the dentin has more organic properties, more organic composition than the enamel, so it's going to travel more quickly through the dentin, and then if it gets close to the pulp, then it can actually cause the pulp to become irritated, and if the bacteria from the decay gets into the pulp, it can actually infect the pulp, and this is what causes a toothache, and it can eventually lead to the formation of a dental abscess. All right, so now that you understand the components of the teeth, let's discuss the supporting structures of the teeth. The periodontium is what supports the teeth within the alveolar bone and consists of the cementum, which we just talked about here on the root surface of the tooth, the alveolar bone, and the periodontal ligament. The periodontal ligament, you see here, these little purple fibers surrounding the tooth. The tooth is not in bone like concrete, okay? It has this little ligament, almost like a shock absorber that's around the root of the tooth. And that's that periodontal ligament, which is what actually connects the tooth to the bone. Okay, these tissues help protect the tooth. They nourish the tooth because they have blood vessels. They also help protect the tooth as part of the immune response. All right, so the alveolar processes are extensions of bone from the body of the mandible and the maxilla. The alveolar bone supports the teeth in their functional positions in the jaws. The alveolar bone is formed by the osteoblasts and the osteoclasts, which we discussed before, which are responsible for the bone resorption, the bone deposition, and also the remodeling of the bone. Now, the alveolar process develops in response to the growth and development of the teeth. So if the teeth don't develop there, then there's no alveolar bone. All right, so once the teeth are lost, if the teeth are extracted, or the bone from the alveolar process resorbs, and then that ridge of alveolar bone decreases in size, and it also changes in shape. So again, as we discussed before, the cortical plate, you can see where these arrows are pointing here. It's a little bit easier to see in this portion here. This cortical plate is dense and it's more radiopaque than that spongy trabecular bone that makes up the central part of the alveolar process. Now, the alveolar crest is where the arrows are pointing here. The alveolar crest here is the highest point of the alveolar ridge. Now, the crestal bone should be pointed, okay? But here, as you can see in this radiograph, it appears flattened, okay, and a lot of times are blunted, and a lot of times in the case of periodontal disease or gum disease, you'll begin to see, rather than seeing really nice and pointed alveolar crest, you'll begin to see flattened or blunted alveolar crest. All right, so the third attachment apparatus, which attaches the tooth to the bone, is the periodontal ligament. It's also known as the PDL, and that is a dense connective tissue, and that's organized into different fiber groups that connect the tooth, that connect the cementum, which is what covers the root of the tooth, with the alveolar bone of the socket wall. So the PDL is both supportive and protective. Okay, those fibers are designed to support the tooth in the socket, as I mentioned before, and they act as a kind of a sensory receptor, which is necessary for the proper positioning of the jaws during normal function. In other words, they provide proprioception, so that way you don't bite down too hard and break your teeth while you're chewing, and that way you know where your teeth come together, so that you're not biting down way too hard and fracturing teeth. So the PDL consists of 3 different types of fiber groups. And we're going to talk about those. The periodontal fibers are the first type of fiber groups. Those fibers support the tooth in the socket. And you can see here in this figure, the periodontal fibers consist of 4 fiber groups named for their location. Okay, so we've got the alveolar crest, we have the horizontal, you can kind of see those going from left to right, you've got the oblique kind of going diagonally here, and then you also have the apical group of periodontal fibers. And the oblique, which you can see here in the middle portion of the root, those are the most numerous, and they constitute the main way that the tooth is attached. Okay, the second set of fibers is the transeptal or interdental fibers. Okay, and those support the tooth in relation to adjacent teeth, and they also support the interproximal gingiva. The interproximal gingiva is the gum tissue that is in between the teeth. We call this area interproximal, in between 2 teeth. The third group of fibers are the gingival fibers. Those are the fibers that support the gingiva that actually surrounds the tooth, the gum tissue that surrounds the tooth. Those are divided into 4 groups. Okay, we're going to point out those. We've got the dentinogingival, the circular, the alveolo-gingival, and the dentoperiosteal. Basically, those are, you can kind of look to see the way the different fibers run in that gingiva. All right, so the gingival unit is the final supporting structure that we're going to discuss, and it refers to the oral mucosa, which it almost continuously lines the oral cavity. It's composed of stratified squamous epithelium, and that overlies connective tissue and includes ducts of salivary glands. So you can kind of see how all these different tissue types that we discussed in the very beginning of the lecture are combining together to form the different structures of the body. So there are different types of mucosa that are found in different areas of the mouth. Lining mucosa is more delicate, and it's known for its softer texture, its moist surface, and its ability to stretch and be compressed. And so you'll find lining mucosa on the inside of the cheeks, the vestibule, which is what we call this area here between the bone and the lip. This little area here is the vestibule. It also covers the lips, the soft palate, and the ventral surface of the tongue. It's also known as unattached mucosa because it's not bound down to the underlying bone. Now, masticatory mucosa is another type of mucosa that has a rubbery surface texture and is resilient. It includes the attached gingiva. So here you'll see the unattached gingiva, or that lining mucosa, and then labeled as B in this figure, and then also on A, you'll see that's masticatory, or what we normally refer to as attached gingiva. And again, you can see there's a difference there in the way that those appear. This is very easily stretched. This is appears much thicker, and is really bound down to that underlying bone. And you have attached mucosa or attached gingiva on the hard palate as well, and you also have masticatory mucosa on the dorsum of the tongue, or that upper surface of the tongue. The dorsal surface, or the top of the tongue, also contains specialized mucosa, and that is present in the form of lingual papilla, which are associated with taste. All right, time for another break. Next we're going to discuss head and neck anatomy. Now we're not going to be discussing head and neck anatomy of giraffes, we're going to be discussing head and neck anatomy of humans. This is another animal, another giraffe that I saw on the safari in the Masai Mara. It was literally the most amazing experience ever. Literally like the Lion King when you crest the hill and look over and just see all these beautiful, majestic animals in their natural habitat. It was amazing. So take a break. I'll see you back in a minute where we will discuss the next chapter of head and neck anatomy. Okay, so in Chapter 9, we'll discuss head and neck anatomy, and this is going to be the clinical foundation for the practice of dental assisting. You're going to learn the names and the locations of the bones of the skull and the face, the facial nerves, the lymph nodes, the salivary glands, and the muscles of the head and neck that are responsible for facial expressions and those that allow you to open and close your mouth and chew your food. So your knowledge of the anatomical landmarks is absolutely a necessity as you begin to take radiographs, as you place them in the correct order, whether that's the traditional film or the digital radiographs. And it's real important that you learn all these new terms and are able to precisely and completely describe regions of the head and neck. All right, so let's talk about the head, okay? The regions of the head. It's divided into the regions that you see here. You've got the frontal, the parietal, the occipital, the temporal, the orbital, the nasal, the infraorbital, the zygomatic, the buccal, the oral, and the mental regions. All right, so the human skull is divided into two sections. We've got the cranium and the bones of the face. So there are 8 bones of the cranium, and they cover and protect the brain. There are 4 single bones in the cranium, the frontal, occipital, sphenoid, and ethmoid, and then there are 2 paired bones, the parietal and the temporal. There are 14 bones in the face. You've also got 6 auditory bones. Those are the bones that are found in the middle ear, so there's 3 bones in each ear, for a total of 6 auditory bones. All right, so we've got several views of our skull here. Figure 9.2 is a lateral view right here from the side. Figure 9.3, this is the frontal view. Figure 9.4, that's the posterior view of the skull. And then figure 9.5, that's the external base. So if you took off the lower jaw here and then turned the skull upside down, then you would see the maxilla, the upper jaw here of the skull. So we're going to talk just a few of the highlights here. The frontal bone forms the forehead. You can see that here. Most of the orbital roof and the anterior cranial floor. Okay, the occipital bone forms the back and the base of the cranium and part of the walls of the orbit. The back and the base of the cranium. The sphenoid bone forms the anterior base of the skull and part of the walls of the orbit. The ethmoid bone forms part of the orbit and the floor of the cranium. The parietal bones form most of the roof and the upper sides of the cranium. And the temporal bones form the sides and the base of the cranium. So spend a few minutes just looking at the figures in your book and looking at the figures and just becoming familiar with the different portions of the skull. All right, so let's talk about the bones of the face. Now that we've discussed the bones of the cranium, let's move on to the bones of the face. So the zygomatic bone there's actually 2 zygomas. The zygomatic bone forms the cheeks. So that, again, that's one of those paired bones. The upper and the lower jaw, the upper jaw and the hard palate are formed from the maxillary bones. Now the maxilla is what houses the maxillary sinuses. Okay, the maxilla is here, and it houses the maxillary sinuses and also the maxillary teeth. The palatine bones, or the palatine bones, form the posterior part of the hard palate. Okay, so you've got the palatine bones forming the hard palate, the floor of the nose, and also the lateral walls of the nasal cavity. Okay, the nasal bones form the bridge of the nose. See that here. The lacrimal bones make up part of the orbit at the base or the inner angle of the eye. You can see those right here. And the next bone that we're going to talk about is the vomer, and that's a single flat bone that forms the base for the nasal septum. And the nasal concha form the lateral wall of the nasal cavity. And the final bone and the final facial bone that we're going to discuss is the mandible. The mandible forms the lower jaw, and it's the movable bone of the skull. The mandibular teeth are housed within the mandible, within that alveolar process of the mandible. And prenatally, it develops in 2 parts and then hardens into a single bone during childhood. All right, so I'm going to point out a few notable areas of the mandible. The mental protuberance is here, or the chin, and that reaches full development during puberty. The angle of the mandible, get my arrow here, the angle of the mandible right here is where the body of the mandible which is this body here, meets the ramus, or this section of the mandible. The coronoid process is the anterior portion of the ramus, whereas the posterior portion, or the back portion of the ramus, is called the condyle. So you have the ramus, the body, the coronoid process, and the condyle. Okay, now the condyle is part of the TMJ, or the temporomandibular joint. And the mandible is actually attached to the cranium, or to the skull, by ligaments, and it's held in place by the muscles of mastication. Another thing to point out on the mandible is the mental foramen. Okay, this little hole right here. It's located on the facial surface, and it's typically between the premolars, okay, between the first and second mandibular premolar. And this is where the terminal branch of the inferior alveolar nerve exits the mandible. We'll discuss that in more detail, but the inferior alveolar nerve goes in right here and traverses through the mandible, and then it comes out the mental foramen here. Okay, so again, the inferior alveolar nerve, you can see, enters the mandible at what we call the mandibular foramen, and then exits the terminal branches of that nerve, exits the mental foramen. And many times you can see this little foramen on a radiograph. It'll show up as just a little radiolucent circle right there, and that's exactly where that nerve exits. So when we anesthetize mandibular teeth, we give what we call a mandibular block, or a nerve block. So we're depositing local anesthesia right here where that nerve, right before it enters the mandible, we deposit that anesthetic right there so it can block this nerve. We can also anesthetize this mental area here, the mental branches of that inferior alveolar nerve, by depositing some local anesthetic right around this mental foramen as well. Okay, so let's talk a little bit more about the temporomandibular joint, or the TMJ. So, many times you'll hear people say that, oh man, I have TMJ, my jaw is just killing me, I have TMJ. Well, of course, most people have two TMJs, okay? So really what they're talking about here, the proper terminology is, I have TMD, or temporomandibular joint disorder, okay? The TMJ is a joint on each side of the head that allows for movement of the mandible during speech and mastication, which we also said is another word for chewing. So the joint is composed of the temporal bone and the mandible, hence the name temporomandibular joint. So you can feel your TMJ by putting your finger right in front of your ear and then opening and closing your jaw. You can feel that, where that TMJ is located. So the mandible, again, as we said before, is attached to the cranium by ligaments, and it's held in place by the muscles of mastication. So let's look at this joint in a little more detail. The glenoid fossa is an oval depression in the temporal bone, which is just in front of or anterior to the external auditory meatus, and it's lined with a fibrous connective tissue, and this articular eminence that you see here, let's see if I can get my, so this glenoid fossa here, here's your external auditory meatus, and then you've got the glenoid fossa, and then this is actually the articular eminence, okay, and that's that raised portion of the temporal bone that's just in front of this glenoid fossa area. So the TMJ is completely enclosed by a fibrous joint, or a fibrous joint capsule, or a capsular ligament. And what this does is it helps support that joint. So the area between the capsular ligament and the surface of the glenoid fossa is known as the articular space. So this area here, and it contains the articular disc, or the meniscus. So this area right here. So what this disc is a cushion, okay, and it's very dense. It's a very specialized connective tissue, and it divides the space. This little disc right here divides the space into an upper compartment and a lower compartment. Okay, these compartments have synovial fluid, and what that fluid does is it helps lubricate that joint to make it easy to move during chewing and during speech. Okay, so the mandible, let's talk about the opening and the closing of that mandible and the shifting from side to side. The TMJ allows the joint to have two different types of motion, the hinge action and also a gliding motion. So during hinge action, or the first part of opening, that condylar head, the condyle of the mandible, right here, this joint, rotates around a point on the undersurface of that articular disc that we just saw. And the body of the mandible, this area right here, this body of the mandible drops downward and backward. Okay, there's 4 different muscles that are involved in jaw opening, and then 3 different muscles that are involved in the closing of the jaw. So that's the hinge action. The gliding movement of the jaw allows the jaw to shift from front to back and side to side. So you can take just a second to do those motions. So opening and closing, front to back and side to side with your own jaw. So that gliding movement involves both the upper and the lower portion of the jaw. So as we saw on the last slide, the articular space is divided into the upper and the lower compartments by that articular disc. So again, you can see that here. So here we've got that articular eminence, that bone, the temporal bone. We've got the glenoid fossa, and then we have that disc that's in between the temporal bone and the condyle here of the mandible. And so as the condyle and the articular disc, you can see here's the hinge action, and then here's this gliding and hinge action. So you can see that the condyle and this disc glide forward and downward along this articular eminence right here. So as the jaw moves forward, this is known as protrusion. And when the jaw goes backward, that's called retrusion. So protrusion, forward. Retrusion is the sliding backward of the jaw. Lateral movement of the jaw is what's described as the side-to-side movement of the jaw. So what happens when the joint does not function properly? Well, that's when you have TMD, or temporomandibular disorder. And the causes, the TMD can be very, very complex, and it can involve many different causes. One common cause of jaw pain is clenching and grinding of the teeth. Now, clenching occurs when the teeth are held together very tightly together for long periods of time, or many times intermittently, on and off. Now, bruxism is the term that's used to describe the grinding of the teeth, which can often occur at night while the patient's sleeping. So many of you may have bruxism. You may clench or grind your teeth. So other sources of TMD, or temporomandibular disorder, can involve trauma, such as would occur like during a fall, or if you get a blow to or strike to the face, or even in a car accident. Those types of injuries can cause problems with the TMJ. Also, other causes of TMD can include diseases of the joint, such as osteoarthritis, or even malocclusion, and that can cause TMD. Now, malocclusion is the condition that describes when the upper teeth and the lower teeth are misaligned. They can be crowded, or they're not in proper alignment, or if there's an incorrect relationship with one another. So like the upper teeth and the lower teeth do not come together properly. This can produce abnormal strain on the joint and can cause pain. So many times, the diagnosis and treatment of TMD can be very difficult, and it can require the involvement of dentists, orthodontists, prosthodontists, oral surgeons, and even many times we have to include physicians in that treatment, neurologists, neurosurgeons, and even psychiatrists. So if you'll look at Table 9.3, you'll see a list of a few of the categories of TMD. So what are some symptoms of TMD? And it's important to note these symptoms in the clinical record during that new patient appointment, during the evaluation, or anytime anytime changes occur in the patient's in the patient's condition, such as at hygiene visits or recall visits. Some of those symptoms may include pain. The patient may complain of headaches. They may complain of pain in their ear or around their ear. Many times, patients have already seen their physician. They've ruled out ear infections, and now they come to us because they're having ear pain. Pain can also occur during chewing. It can occur on opening, or they can even have pain because of muscle spasms in that area. Other symptoms of TMD can include joint sounds, and so those are important to also evaluate and note, whether you hear any clicking or popping or crepitus, any sounds when that patient is opening or closing. Another symptom can be limitations in movement. Patients may complain about they can't open wide when they eat or when they yawn, or they may have pain during those motions. So you can measure a patient's ability to open by measuring what we call their maximum incisal opening, and that's just the distance in millimeters between the incisal edges of the maxillary and the mandibular teeth, and that you ask the patient, open as wide as you can, and then you take a ruler and measure in millimeters that distance. And so, it's important to note, especially in patients that have restricted movement. We want to be able to measure that on occasion. So it's good to have a baseline of what that patient's maximum incisal opening is. They can also have trismus, or spasm of the muscles of mastication. Those are the muscles that surround that joint. If you have trismus or the spasm of those muscles, that can restrict movement, and it can keep the patient from being able to open wide or even open at all. Trismus can occur after an injection of local anesthesia or even as a result of a dental infection. So you may have, patients may report that their jaw even locks or gets stuck open, and this happens when that condyle moves too far forward and actually gets stuck anterior to the articular eminence. So I'm going to go back on that slide previously and just show you. So what happens a lot of times when they say my jaw gets locked open is, in normal movement, this condyle will kind of slowly go down, slide down out of the glenoid fossa down the articular eminence. If this condyle comes forward so far that it actually gets stuck here in front of or anterior to the articular eminence. This is your ear back here, this is your nose up here, comes forward, gets stuck here, then it can't be, cannot go back into place. So what happens is you have to pull that lower jaw down first and then push it posterior. A lot of times people panic and they start trying to push their jaw back, and it's not going to become unlocked because that condyle cannot get back underneath that articular eminence without being pulled down first and then back around. All right, so TMD treatment can vary depending on the specific diagnosis and the symptoms, and it can range from behavior modification, avoiding chewing gum, avoiding hard, crunchy foods. It can mean, applying moist heat to the jaw area. Treatment can also include occlusal guards or splints, and it can even involve surgery of the TMJ. All right, so it's important to know the location of and action of the muscles of the head and neck. We've looked at the bones of the head and neck. Now we're going to look at the muscles of the head and neck, because their malfunction can be involved in malocclusion, TMD, and even infection, the spread of infection, which can be caused by an abscessed tooth. All right, so muscles contract and expand, as we mentioned before, and that's what makes movement possible. So each movement, each muscle has a point of origin, and that is where it's important to understand this concept. Each muscle has a point of origin, and that's where the muscle is fixed. In other words, the point of origin, it's not movable at that point. Then the muscle continues and goes to a point of insertion, which is movable. So I think of it like a tree trunk and a branch. Okay, the origin is that tree trunk, and then that tree trunk cannot move, but it extends branches out. Those branches can move, okay? The branches are like the insertion points of the muscle, which are movable. So there's 7 main groups of muscles in the head and neck. Okay, we're going to talk about each of those. So the first group, the muscles of the neck. Okay, both of those muscles can be palpated easily. And can become painful to you as a dental assistant if you're not using correct posture. And those are the sternocleidomastoid and the trapezius. Now your book has figures that show these in more detail. So this is, especially important, again, as you're beginning your dental career as a dental assistant. You really want to start out from the beginning with good ergonomic, good posture habits, because if you have poor posture, that's going to really limit your years in the dental profession. It's going to cause a lot of physical, neck pain, headaches. So it's really important right off the bat that you pay attention to your posture. So the next group of muscles, the muscles of facial expression, those are listed in Table 9.5, and those describe that table describes the function of each muscles. Now these muscles originate from the bone, and they insert into the skin tissue. So again, you can see the origin is non-movable and the insertion of the muscle is movable. Now these muscles are innervated by the 7th cranial nerve, and we'll talk more about the cranial nerves in a minute, but that 7th cranial nerve is also known as the facial nerve. Easy to remember. It innervates muscles of facial expression. The next group of muscles that we're going to talk about are the muscles of mastication, as seen in figure 9.15. And those are listed in Table 9.6. There's 4 pairs of muscles that are attached to the mandible that are involved in chewing, and those include the temporalis, the masseter, the internal or the medial pterygoid, and the external or the lateral pterygoid. Now the muscles of mastication, they're innervated by the mandibular or the 3rd division of the trigeminal nerve. Okay, that's also known as the 5th cranial nerve. So that 3rd division is also known as V3. And again, we'll talk about that more in a minute. The masseter is the strongest muscle of mastication. And you can actually feel your masseter when you place your hands on the side of your face and clench your teeth together. That's the masseter muscle that you feel there. So in this picture here, you can see this is the masseter. It's that large muscle right there. When you clench your teeth together, a lot of times you can feel right above the ear. You can feel that temporalis muscle as well. All right, so the next group, the muscles of the floor of the mouth, or there are the region of the mouth under the tongue. Those are listed in Table 9.7 and include the digastric, the mylohyoid, the stylohyoid, and the geniohyoid. Now these are located between the mandible and the hyoid bone. Okay, the hyoid bone is shaped like a horseshoe, and it's unique because it doesn't actually articulate or connect with any other bone. It's suspended between the mandible and the larynx, and there's several different nerves that innervate these muscles. We're not going to talk specifically about those. The next group, the muscles of the tongue. Okay, those are divided into 2 groups, the muscles within the tongue, or the intrinsic muscles, and then also the muscles that are on the outside of the tongue. So the muscles that you see in this picture here, those are the extrinsic muscles of the tongue, and the intrinsic muscles shape here's the tongue right there. Those intrinsic muscles are what shape the tongue during speaking, chewing, and also during swallowing. And the extrinsic muscles allow the tongue to protrude or stick out. So it allows you to stick your tongue out at somebody and retract. Those allow the tongue to elevate or depress within the mouth. And this figure, 917, shows those extrinsic muscles of the tongue. The next group, the muscles of the soft palate. Oops, sorry about that. The muscles of the soft palate, there are two major muscles. Those are the palatoglossus and the palatopharyngeus. And then finally, the muscles of the pharynx. Those are the muscles that are involved in swallowing. All right, so next let's talk about the salivary glands. We touched on those briefly earlier, but the salivary glands produce saliva, and that saliva not only lubricates and cleanses the oral cavity, but that, as we discussed before, that is actually what begins the process of digestion. And the saliva contains minerals which can not only assist in the remineralization of teeth. If you have that enamel that begins to get softened and break down and become demineralized, the minerals in the saliva can help remineralize that enamel, but it also can cause the dental plaque that forms on teeth to form into tartar, or what we call calculus. Okay, we'll discuss these concepts in greater detail in Module 4. All right, so let's talk about the two different types of saliva. You have serous and mucus. All right, serous is a watery saliva. It's composed mainly of proteins, and this type of saliva is produced by the parotid gland. Mucus, on the other hand, is very thick, and it's composed mainly of carbohydrates. The submandibular and the sublingual glands produce a mixture of mucus and serous saliva. All right, so the salivary glands, we can categorize those as major or minor. Now, the minor salivary glands are smaller, but there are many more of them. Okay, they are scattered in the tissues of the mucosa, in the soft palate, the lateral portions or the side portions of the hard palate, and also in the floor of the mouth under the tongue. And you can even have a salivary gland that's associated with the tongue, and that's located on the circumvallate lingual papilla. And this is called von Ebner's salivary gland. Now, the three major salivary glands, I mentioned those briefly a second ago. You've got the parotid gland, the submandibular gland, and then also the sublingual gland. Okay, let's talk about those in a little more detail. The parotid gland is located just below and in front of the ear. It's the largest of the salivary glands, but it only produces about 25% of the total volume. And as we mentioned before, the parotid produces that serous saliva. So only about 25% of the total volume of the saliva comes from the parotid gland, and it empties into the mouth through this area here. When you look inside the mouth, you can kind of see this parotid papilla. It's usually right around the area of the maxillary second molar. A lot of times you'll see a little more calculus forming on that surface of that tooth up there, because this salivary gland empties right here through Stenson's duct, and it helps, it can cause that plaque that's on that second molar harden and form tartar a little bit more easily. The submandibular gland is located in the submandibular fossa, and it's the second largest salivary gland, and it produces the largest volume of saliva, with about 60 to 65% of the total volume, and it empties through the mouth in this little area right here through a duct called Wharton's duct. Stenson's duct is where the parotid gland empties. Wharton's duct is where the submandibular gland empties. Now, the sublingual gland is located under the tongue, right here. And you'll see that it's the smallest of the three major salivary glands, and it provides only 10% of the total volume of saliva, and it releases saliva into the oral cavity. You can see right here through Bartholin's duct and other smaller ducts. Okay, so occasionally you'll have a salivary gland that can become blocked by a little calcified stone or a sialolith, and it will have to be removed surgically in order to allow that salivary flow to continue in the mouth. So you can see on this picture here that little white stone right there is lodged in a salivary duct and can become quite painful, as saliva cannot continue to pass through that duct and empty into the mouth as normal. And you can even see those stones, those calcifications on radiographs. You can see right here that's a sialolith that's in a duct underneath the tongue. All right, so let's talk about the blood supply to the head and the neck. And it's important to know these structures because these can be compromised by disease or during procedures such as surgery or the administration of local anesthesia. They can also play a big part in the spread of infection. So in this figure 920, it shows the major arteries and veins. Arteries are typically pictured in red because, as you will recall, they carry rich oxygenated blood away from the heart. Arteries carry blood away from the heart to the rest of the body, and the veins, on the other hand, can carry blood from the extremities back to the heart to be oxygenated by the lungs. So now the major arteries that we're going to discuss here, the common carotid artery, right there, arises from the aorta. You'll recall back to that picture of our heart before. That aorta is the largest artery that arises from the heart. It then divides in that common carotid artery, then divides into the external carotid, which you see here, and then the internal carotid right here. So when you check your pulse in your neck, what you're actually feeling, that's actually your carotid artery. So the internal carotid artery, this branch that you see here, that's what supplies the blood to the brain and to your eyes. The external carotid here is of more importance to us from a dental standpoint because that has several branches that supply, that's the major blood supply to your face and to your mouth. One of these branches is the facial artery that you can see right here, and that enters the face at the inferior border of the mandible. So let's go back to the common carotid. We've got then it branches to the internal carotid, and then you see the facial artery. So it enters the face at the inferior border of the mandible, and you can actually feel it by palpating this mandibular notch. So find the angle of your mandible right here, and this little notch right there, you can actually feel that facial artery. And a lot of times, because it's an artery, it's closer, blood coming from the heart, you can a lot of times feel a pulse in that facial artery. Another branch of the external carotid artery is the lingual artery. So there's the facial artery. The next is the lingual artery, and that has several branches. That, as the name suggests, it supplies blood to the tongue, the floor of the mouth, the gingiva on the lingual side of the mandible, and also a portion of the soft palate and the tonsils. The external carotid also branches again to form two terminal branches. So we followed that common carotid, the external carotid, we had the facial, the lingual, and then it continues on to two terminal branches. Those two terminal branches are the superficial temporal artery, which you see right here, and then the maxillary artery, which continues here. Okay, and then you can see several other branches. The maxillary artery has three branches. You see the inferior alveolar, the pterygoid, and then also the pterygopalatine, which we can't really see those branches in this, labeled in this figure. Okay, so the major veins, let's talk about those for a few minutes. The veins take the blood, again, from the head and neck back to the heart and the lungs to be reoxygenated. So it's important to understand the connection between dental infection and the facial vein. Okay, the facial vein, which you can see right here, has communications with the cavernous sinus. Okay, and that is located in the brain. And so, this is how, when you have a dental infection or a dental abscess caused by an infected tooth, this is how those abscesses have the potential to become life-threatening. Okay, because that bacteria, that infection, can go from this facial vein, it can communicate with the brain via the cavernous sinus. There's no valves in that particular vein. So one thought is that the lack of valves, allows that blood to communicate with the cavernous sinus in the brain, and can have the potential to have serious life-threatening complications for the patient. So that's why it's important, that we stress to patients that have dental infections, well, actually to prevent dental infections, of course, but then, also it's important to quickly treat dental infections, because they can, especially maxillary abscesses of the teeth in the upper jaw, can be life-threatening and causing brain abscesses and even ultimately death. All right, so we talked about major arteries, major veins. So the next slide, we're going to talk about the nerves of the head and neck, and it's important, again, to know the location and the names of these nerves, because it's important during the use of local anesthesia during dental treatment, because we want our patients to be numb so they're not in pain while we're providing treatment. And it's important to understand conditions and disorders of the nervous system which can affect the face, and we discussed a couple of those earlier. There are 12 cranial nerves. Let's back up here. 12 cranial nerves exiting from the brain and the cranium. Okay, these nerves provide both sensory and motor functions. So again, when we were talking about the nervous system, we said nerves have the potential to be sensory or motor. They allow sensation as well as movement. So they allow us to sense certain stimuli, environmental stimuli, but then they also allow us to move our muscles. The nerves, are given names based on the area or the function that they serve, and they're numbered using Roman numerals. Okay, so in dentistry, we are most concerned, this is figure 922 in your book, and it lists all of the cranial nerves, and that you'll see some of them are sensory, some of them are motor, and then some of them are actually can be sensory and motor. So I'll let you read what the functions of each of those cranial nerves. I'm going to hit the high points of the ones that are the most important to us in dentistry. We're most concerned with cranial nerve 5, the trigeminal nerve, cranial nerve 7, which is the facial nerve, cranial nerve 9, which is the glossopharyngeal, cranial nerve 10, the vagus nerve, cranial nerve 11, which is the accessory, and cranial nerve 12, which is the hypoglossal. So let's talk about the trigeminal nerve, or cranial nerve 5. It provides the majority of the innervation for the oral cavity. It's got 3 branches. V1, or the first branch, is the ophthalmic, and so we're not going to be discussing that one any further. V2 is the maxillary division, or the maxillary branch, and V3 is the mandibular branch. So let's go back here. V2, okay, that's the second division of that trigeminal nerve, the 5th cranial nerve. It divides further into the nasopalatine, the greater palatine, the anterior superior alveolar, the middle superior alveolar, and the posterior superior alveolar nerves. Usually you'll see those listed as ASA, MSA, and PSA for short. And V2 also supplies innervation to the maxillary teeth, the periosteum, which is that outer covering of the bone, the mucous membrane, the maxillary sinuses, and the soft palate. So you can see in this picture, here is the trigeminal nerve here, and then it's 3 divisions, V1, V2, and then V3. So you can see here is described all the branches of the maxillary division. So when we're anesthetizing anterior teeth to work on those teeth or the gum tissue in that area, we are anesthetizing the anterior superior alveolar nerve branch, which is a branch of V2. Same thing again, the premolar region, canine and premolar region, we're anesthetizing that MSA, posterior teeth or the molar teeth, we're anesthetizing the PSA. So let's talk about the V3 or the mandibular division of the trigeminal nerve. It divides further into the buccal, lingual, and inferior alveolar nerve branches. The buccal nerve supplies innervation to the buccal mucosa or the buccal mucous membranes and the mucoperiosteum of the mandibular molar teeth. The lingual nerve, as it sounds, innervates the anterior 2/3 of the tongue. So the front 2/3 of the tongue, the lingual mucous membranes, and the mucoperiosteum of the lingual surfaces. The inferior alveolar nerve further divides into the mylohyoid nerve, the mental nerve, the incisive nerve, and the small dental nerves innervate the molar and premolar teeth, the alveolar process, and the periosteum. All right, so finally we're going to discuss the lymph nodes of the head and neck. And it's important to know the location and function of these lymph nodes. When you're completing an extraoral examination, we will be palpating these lymph nodes, so it's important to know where they're located. Enlarged lymph nodes can indicate the presence of infection or even cancer. Oftentimes, the first sign of carcinoma or cancer of the head and neck is swollen lymph nodes. All swollen lymph nodes are not cancer, though, okay? Many times they're going to be a sign of some type of localized infection. Now, the term for enlarged lymph nodes is called lymphadenopathy. And now, an enlarged lymph node contains lymphocytes. This is review. We discussed this previously. And those lymphocytes assist in helping the body fight infection. Now, lymph nodes are small, round, or they can be oval, and they're found throughout the body. Let's see if we've got we don't have that large picture. Okay, so they can be found throughout the body. You can see the little lymph nodes here in this picture of the head and neck area. Those major sites of those lymph nodes are cervical lymph nodes, which you see here in the neck. You can also have axillary lymph nodes under your armpits. You have inguinal lymph nodes in the lower abdomen or the groin area. So the lymph nodes for the oral cavity, they drain intraoral structures such as the teeth, the eyes, the ears, the nasal cavity, and deeper areas of the throat. You can have superficial lymph nodes, or you can have deep lymph nodes, and you can see here the superficial lymph nodes are on the top picture here, and then those deeper lymph nodes are in the lower picture here. They can be, there's 5 groups of actual superficial lymph nodes that we're going to talk about. Occipital, see those here. Retroauricular, those are here. Anterior auricular, which are those, let's see if I can find my arrow here. Those right here, you can see your reference point here is that external auditory meatus. So you've got your retroauricular, your anterior auricular, and then you've got the superficial parotid. Those are right around the parotid gland here, which we talked about when we were discussing saliva. And then you've also got various facial nodes throughout the face here. The deep cervical lymph nodes, on the other hand, down on this lower picture, are located along the internal jugular vein, which you can see right here, on each side of the neck, and they're deep to that sternocleidomastoid muscle. okay, which has been stripped away. This would the muscle, you can see it better up here, right here. You peel that back and then you see these layers of deep lymph nodes. All right, now finally, let's talk about the sinuses. The paranasal sinuses are air-filled spaces or cavities within the skull that communicate with the nasal cavity. So the sinuses, there are different sinuses and they're all named for the bones where they're located. So you see here the frontal sinuses are located within that frontal bone. The ethmoid sinuses are within the ethmoid bone. Sphenoid sinuses are within the sphenoid bone. And then the maxillary sinuses are in the maxilla. Usually when you hear people talking about, oh, my sinuses are killing me, usually a lot of times they're referring to having pain with their maxillary or even their frontal sinuses. Now the sinuses, the functions include they produce mucus. They make the bones of the skull lighter because they're air-filled cavities. And they also provide resonance, which helps produce sound. Now, the maxillary sinuses are the largest of the paranasal sinuses, and they're located, again, within the maxilla. And you will oftentimes see a maxillary sinus on the radiographs, either on a periapical radiograph, sometimes you'll see them on a bite wing radiograph, and certainly on a panoramic x-ray, you'll see those in the location of the posterior teeth. Now, the location of the sinus is important during surgical procedures such as extractions and the placement of dental implants. So again, we'll be discussing those in further detail. This lecture has been a good baseline, a good foundation for you that we will continue to build upon in the future. All right, so this is the final slide. You can celebrate. We are finished with Module 2. Again, this is a picture. The last picture I'll show you from the safari on the Masai Mara of a little lioness and her cubs here hanging out in the trees. So again, if you have any questions, comments, feedback, suggestions, please feel free to send me an email. My email address is listed on the screen, as is my phone number. You can please call or text me if you have any questions. This week in your clinical session, you're going to be discussing making notes in the patient's chart. You're going to be practicing sterilizing dental instruments, setting up a basic dental tray, and flossing. I want you to have fun. Again, please let me know if you have any questions. And now that you've finished Module 2, the video, you can go ahead and take the quiz. Good luck, and until next time, keep smiling.